मंगल मूरत अधिकारी, होगी सूरज प्रकाश ऐसी छवि तेरी, गंडस्थल मदमस्तक चुले शशि बिहारी। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव। भाव भगत से कोई शरणागत आवे, संतत संपत सब ही भरपूर पावे। ऐसे तुम महाराज मोको अति भावे, गोसावी नंदन निश दिन गुण गावे। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव जय देव जय देव जय मंगल मूर्ति, दर्शन मात्रे मान कामना पूर्ति। जय देव जय देव जय देव जय देव जय मंगल मूर्ति, दर्शन मात्रे मान कामना पूर्ति। जय देव जय देव। गणपतिये नमो नमः, श्री सिद्धि विनायक नमो नमः, अष्ट विनायक नमो नमः, गणपति बप्पा मोरया, मंगल मूर्ति मोरया। ओम गणपतिये नमो। वक्रतुंड महाकाय, सूर्यकोटि समप्रभ, निर्विघ्नं कुरु मे देव, सर्वकार्येषु सर्वदा। गणपतिये नमो नमः, श्री सिद्धि विनायक नमो नमः, अष्ट विनायक नमो नमः, गणपति बप्पा मोरया, मंगल मूर्ति मोरया। ओम गणपतिये नमो नमः, श्री सिद्धि विनायक नमो नमः, अष्ट विनायक नमो नमः, गणपति बप्पा मोरया, मंगल मूर्ति मोरया। ओम गणपतिये नमो नमः, श्री सिद्धि विनायक नमो नमः, अष्ट विनायक नमो नमः, गणपति बप्पा मोरया, मंगल मूर्ति मोरया। ओम गणपतिये नमो नमः, श्री सिद्धि विनायक नमो नमः, अष्ट विनायक नमो नमः, गणपति बप्पा मोरया, मंगल मूर्ति मोरया। सुखकर्ता दुख हरता वार्ता विघ्नाची, दुर्वी पूर्वी प्रेम कृपा जयाची, सर्वांगी सुंदर उटी शेंदुराची, कंठी झळके माळ मुक्ता फळांची। जय देव जय देव जय देव जय देव मान कामना पूर्ति जय देव जय देव रत्न खचित फरा दुज गौरी कुमरा चंदनाची उठी कुमकुम केशरा हीरे जडित मुकुट शोभतो बारा ऋण सुनती नूपुरे चरणी घाघरिया जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव लंबोदर पीतांबर फणिवर बंधना सरळ सुंड वक्रतुंड त्रिनयना काश्रामाचा वाटपा हे सदना संकटी पावावे निर्वाणी रक्षावे सुरवर वंदना जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव शेंदूर लाल चढ़ायो अच्छा गज मुख को तो दिल लाल बिराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव अष्टौ सिद्धि दासी संकट को बैरी विघ्न विनाशन मंगल मूरत अधिकारी कोटि सूरज प्रकाश ऐसी छवि तेरी कंडस्थल मदमस्तक चुले शशि बिहारी जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव भाव भगत से कोई शरणागत आवे संतत संपत सब ही भरपूर पावे ऐसे तुम महाराज मोको अति भावे गोसावी नंदन निश दिन गुण गावे जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन रमता जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव जय देव जय देव जय मंगल मूर्ति दर्शन मात्रे मान कामना पूर्ति जय देव जय देव गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगल मूर्ति मोरया ओम गणपतये नमः वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया
हेलो हेलो गुड मॉर्निंग
उधर की ऑडियो देना हमें।
उधर की ऑडियो नहीं सुनाई दे रही
Can you hear me?
हेलो
Yes, can you hear me?
yeah
this morning?
yeah I can hear you sir yeah good morning we'll start your session at 9:30 IST
9:30, that's how many minutes from now?
it's 28 more minutes
Okay.
okay the organizing committee is yet to come once they reach I'll connect it with you
And how
Again.
do I share my screen, or how do, oh, I see it at the bottom.
screen the green tab you can just
Yeah,
click on the
yeah.
green tab and you can check it right now we'll just have a trial
Alright, so let me get the presentation up. Can you see it?
it's just a white screen which I am seeing over here I request you to first open the PPT at the location then go to the share button and then share it
So I have it on the screen now.
just a minute come on I'm sending a command to you you just accept this request yes yes it is visible to us make it full screen sir
Alright, allow the applications below. So which one? The Zoom?
yes it's Zoom sir yes
Can you see it now?
yes you just down the other windows okay just do the PPT on full screen mode
Okay.
yes yes it is well visible and yes it's
Alright,
okay
I'll have to get the other presentation up as well.
what is
I said I have two presentations, so
yes
I'll just make
Once you finish the one, then you can share the other one.
All right.
Right, sir. So I'll get back to you after 10-15 minutes.
All right. So should I just leave this open like I have it?
What is?
Should I just leave everything open like this?
Yes.
All right. That way there won't be any mistakes. Okay. Good.
Right, sir.
All right. Thank you.
Thank you, sir.
Check. Test 1 2. Hey hey. 1 2. Check. Test.
Good morning, everyone. Welcome to the second day proceedings of the conference. Yesterday we had a great time, great sessions, great science, and great music. So we begin the second session on lipids, and may I ask Professor Manchanda to chair the session. Along with him, Professor Sunil Jain from SMS Medical College, Dr. Anshu Kabra, Milind Srivastav, Ankit Gupta, G.K. Garg, Prashant Dwivedi, Ruchi Gupta, Sunil Sharma. So Dr. Rosenson is a professor of cardiology at Mount Sinai Hospital and Medical School in New York. He'll be speaking on Zoom. So over to Professor Manchanda, please.
Thank you for understanding my travel challenges. These are my disclosures. I'm going to integrate a case into this presentation. This 36-year-old male presented with newly detected hypercholesterolemia. 2 years ago, his LDL cholesterol was 152 milligram per deciliter. He was on a low-fat diet. His primary care doctor recommended a more stringent low-fat diet, but paradoxically, the LDL cholesterol increased to 173 milligram per deciliter. Because he was on a low-fat diet, exercise, not overweight, he was referred to our program to better understand his cardiovascular risk and cholesterol disorder. On the examination, he had bilateral Achilles tendon thickenings and a crescendo-decrescendo murmur consistent with aortic valve sclerosis. So at that LDL cholesterol level, the presence of tendinxanthomas in this young man was surprising. Using the Dutch lipid score, he has probable familial hypercholesterolemia. This is in large part based on the examination. But we can see that there's a paucity of other criteria, such as a family history of early onset heart disease and an extremely high LDL cholesterol level in this individual. Heterozygous familial hypercholesterolemia results from defects in the LDL receptor in 90% of the affected individuals. This results in impaired clearance of the LDL particles from the circulation with the accumulation of these particles that can enter the artery, enter the skin, around the eyes, and the tendons. And of course, what we're concerned about, and particularly for the theme of this program, is a high risk of early onset myocardial infarction. These are some of the cardinal symptoms of homozygous FH. Less severe abnormalities are seen in patients with heterozygous FH. But in HoFH, one can get cutaneous xanthomas in children, tendinxanthomas affecting the dorsum of the hand, sometimes over the elbows, and most consistently over the Achilles tendons. You also can detect xanthelasmas and, of course, vascular symptoms. Familial hypercholesterolemia occurs with a frequency of 1 in 244 to 1 in 313 individuals worldwide. And this condition is more common in people with ischemic heart disease, and even more common, affecting 1 in 15 individuals with early onset coronary heart disease. And those who have LDL cholesterol levels greater than or equal to 190 milligram per deciliter, heterozygous FH is present in 1 in 14. So when you have a young person who comes into the hospital with an early cardiovascular event, think about familial hypercholesterolemia as a diagnosis, particularly when their LDL cholesterol level is high. I was asked to focus on genetic testing, and we'll now move into the rationale. The clinical presentation of familial hypercholesterolemia has changed over time because of the more widespread availability of statin therapy. This has influenced our ability to detect xanthomas and corneal arcus, which are only present in less than 15% of affected individuals in the Safe Heart study and about 8% in the Cascade FH registry. The early onset of coronary heart disease in family members, which has really been one of our benchmarks for diagnosing this condition, has also changed, again, due to the widespread availability of cholesterol-lowering therapies often used in individuals in whom a diagnosis has not been made, but they do have elevated LDL cholesterol levels and may be treated for primary prevention of cardiovascular disease. What are the outcomes from genetic screening? Well, it provides greater and more accurate diagnosis that allows us to identify relatives who may have this condition and be unaware of it. And by making a diagnosis from a genetic perspective, therapies are begun at an earlier age, and more non-statin add-on therapies are begun at an earlier age. So it makes a difference for the care of the patient based on data that I will review momentarily. Patients with homozygous FH have the highest LDL cholesterol levels, develop heart disease very early. In individuals with heterozygous familial hypercholesterolemia, the onset of coronary heart disease is variable. In this model, if we would place individuals on low-intensity statins, we could prolong the time till they develop a coronary heart disease event from 35 years to 48 years. And if we used a high-intensity statin, which we should use, then we can actually decrease the onset of coronary heart disease events by 18 years. We also have to be aware that an elevated LDL cholesterol may overlap with common hypercholesterolemia, often polygenic, sometimes secondary due to a high-fat diet. And heterozygous FH LDL cholesterol levels may overlap with patients with homozygous FH. Molecularly, this variability is often due to the type of LDL receptor abnormality and the residual LDL receptor function. Individuals with null mutations have the highest LDL cholesterol levels and the highest risk of coronary heart disease, the earliest onset. Individuals with defective traits, not completely no activity, have an intermediate, albeit very high risk. And then there's individuals who have two different traits, compound heterozygous hypercholesterolemia, which again falls under the umbrella of homozygous FH. As mentioned, the most severe LDL cholesterol abnormalities are seen in patients with LDL receptor null mutations, followed by defective mutations, followed by PCSK9 gain-of-function mutations, followed by missense mutations in apolipoprotein B. And these LDL cholesterol levels can be influenced by polygenes, as I'll discuss near the end of this talk. What's the yield from genetic testing? What are the methods? And what about access? Well, in this review article by Strum, published in the Journal of the American College of Cardiology several years ago, you evaluate individuals who have a family history of early onset heart disease and LDL cholesterol not explained by diet or secondary causes. And if you have a positive genotype but a negative phenotype, you would monitor that individual, treat based on the LDL cholesterol level and guidelines for primary prevention. But if they have a positive genotype and a positive phenotype, their risk for a coronary heart disease event is increased 22-fold compared to individuals with LDL cholesterol levels less than 130 milligram per deciliter. In individuals who have a negative genotype but a high phenotype, you treat them based on guidelines for primary prevention of coronary heart disease. In this analysis by Midcara and Sekatharesan, they reported that in the genetic consortium study, that 1.9% of patients with LDL cholesterol levels greater than or equal to 190 milligram per deciliter had an FH mutation, higher numbers seen in the charged consortium at 8%. The LDL cholesterol levels are higher in people with a genetic diagnosis versus without a genetic diagnosis, and the risk of heart disease is much higher in individuals with a genetic trait and a high LDL cholesterol than a high LDL cholesterol without a genetic trait. And why is this the case? Because these traits were present before the individual was born, and you have the cumulative exposure of a high LDL cholesterol that impacts on this risk. Graphically, we can see the highest LDL cholesterol levels are the individuals with the loss of function mutations in LDLR, and then lower risk in individuals with rare missense mutations in apolipoprotein B. From another study published from the Dutch consortium, you can see the highest LDL cholesterol levels and the highest risk of heart disease in the LDLR FH patients, followed by ApoB, followed by PCSK9, loss of function, or individuals where it was actually protective. What about polygenic risk scores? In that analysis from CARA, second analysis published in Circulation, individuals with FH, high LDL cholesterol levels, but if there's a high polygenic risk score, which means minor genes that increase the LDL cholesterol level, the LDL cholesterol level is even higher. In this analysis by Trinder, similar findings were seen. Here we can see no genetic cause, high polygenic risk, monogenic variant for FH, monogenic variant, and a high polygenic risk score. Those with the most severe genetic abnormalities have this greatest event rate or the lowest event-free survival. Major genes, polygenes, cardiovascular risk. Getting back to our patient, he had a very interesting pattern. He had an LDL receptor mutation, which would explain the diagnosis of familial hypercholesterolemia, why he has tendinxanthomas. But in terms of why his LDL cholesterol level was lower than we typically consider, that's because he inherited a loss of function mutation in PCSK9, so that offset somewhat the high LDL cholesterol from the LDL receptor mutation. So a very interesting presentation, and the genetics provided guidance as to why his LDL cholesterol didn't fit into the typical categories that we consider. Management of HeFH patients focuses on lowering LDL cholesterol less than 70 milligram per deciliter for a heart disease risk equivalent. We recommended that the patient start rosuvastatin 40 milligram daily, but he requested a lower dose, so we started at 10 milligram daily. The LDL cholesterol fell to 72 milligram per deciliter, and last week we added ezetimibe to meet that minimal acceptable target. What do we know about polygenic risk score in PCSK9 inhibitors, which he did not need at this time? Well, if you have a high genetic risk score, not only is your risk higher, but the absolute benefit of treatment is greater, as shown in panel C compared to panels A and B. So again, higher risk, greater treatment benefit, greater efficiency of PCSK9 therapy. With regards to high risk score in the Odyssey studies, the higher the polygenic risk score, the greater the LDL cholesterol levels, as shown in panel B, and the highest risk of coronary heart disease events when you've got a high LDL cholesterol level and a high polygenic risk score. What are some of the limitations of genetic testing? Availability, what that panel offers. Not all panels are as comprehensive as others. You may have a trait that may not be identified, but still have the diagnosis. And then there's traits of unknown significance just because they haven't been studied well enough to link them to risk of heart disease, but they may actually be shown to be associated with early onset heart disease at some time in the future, or they may not be. And so these are known as variants of uncertain significance. Patients are often concerned about genetic discrimination. They're protected in the United States, Canada, and you would know your policies in India. To prevent these individuals from being disadvantaged for insurance coverage, but to get the treatment that they need based on their inherited traits. What are the implications for the family? Well, sometimes there's guilt that a parent passed on this trait to their children, but it needs to be framed in a positive way that identification of an FH trait will result in earlier and more effective treatment based on the data. Individuals may have cost limitations for genetic testing, and something else that is dependent on the practices in your country versus other country and insurances, at least in the United States. In the last few slides, I just want to go over treatment, and I'm not sure if this was covered in the meeting, but if you've got homozygous FH, you start with a high-intensity statin. You evaluate the treatment, because if they have LDLR null mutations, the LDL cholesterol will only fall by about 2 to maybe 8%. Then you add ezetimibe. You would add a PCSK9 inhibitor. Not all patients with HoFH respond. Again, because this therapy protects the LDL receptor from degradation. If they have low residual activity, the treatment response is going to be negligible. And then, of course, there's evinacumab, an angiopoietin-like 3 inhibitor that lowers LDL cholesterol by a non-LDLR receptor pathway, also lumidipide or LDL apheresis. And sometimes these patients with HoFH require more than one of these more advanced therapies. For HeFH, the treatment response with a high-intensity statin is greater. Sometimes they start high-intensity statin and ezetimibe together, depending on the goal of treatment and the baseline LDL cholesterol level. We'll move quickly to a PCSK9 inhibitor. Evinacumab does work, but it's not approved in the United States or elsewhere for heterozygous FH. But this is an important therapy to consider in the future. And then LDL apheresis may be used as well. So to summarize, our ability to detect familial hypercholesterolemia has changed because of the widespread availability of statin and other LDL cholesterol-lowering therapy. Genetic testing may be useful, and cascade screening is important to identify individuals who may not be aware that they have a high LDL cholesterol or a genetic risk that places them at increased risk of coronary heart disease. We also have to keep in mind that there's an overlap in LDL cholesterol levels between people with HO and HeFH. Some of the therapies that are available in HoFH, at least in the United States for orphan indication, are not available for patients with HeFH. So in those individuals with very high LDL cholesterol levels who have a genetic diagnosis, you may be able to achieve better treatment with the use of a drug like evinacumab or lumidipide, or move on to LDL apheresis more quickly.
Thank you. Thank you very much, Professor Rosenson, and good morning, and very, late night in New York. So, any question, please? Any question, please? Early morning in India, and there are lots of people in the audience. Can we go on to your second talk, please, so that you can have some sleep in time? And he'll be talking on lipoprotein A.
Yes, I'm going to stop the share and pull up that presentation.
Good morning, sir. Very informative session for lipidology. I want to know any implication of PCSK9 inhibitors in homozygous familial hypercholesteremia.
Yes, there are studies. We published the largest series, the Odyssey HOFH study. There's about a 30% LDL cholesterol lowering in HOFH. But again, there was quite variable responses. If you have null mutations, you're not going to respond to a PCSK9. So one has to evaluate, the treatment response. And if it doesn't work, you stop the therapy. If it does work, even 30% LDL cholesterol lowering may be important, for that individual.
Thank you. Thank you, sir.
Thank you.
Okay, great. Are we ready to proceed to the second talk?
Yep. Thank you. Yes, please.
Okay. So lipoprotein A is a fascinating lipoprotein, and we're learning more about lipoprotein A each and every day. In this analysis from the European Society of Cardiology scientific statement, they pulled the analysis regarding lipoprotein A and the risk of various disease states. And we can see that there's a concentration-dependent increase in aortic valve stenosis, ischemic stroke, myocardial infarction, and heart failure. In the REGARD study, we showed that LPA is associated with a stronger risk of heart disease than stroke for both black participants and white participants. In this analysis by Wilhite, after adjusting for the Framingham risk score, the Reynolds risk score, we can see that a high LPA level was associated with higher risk of cardiovascular disease with both scores, and adding the isoform, high molecular weight isoform to the LPA level gave similar information as shown in these bottom two lines. So the LPA measurement is an important source of residual risk even after adjustment for age, sex, gender, and major risk factors. With regards to the review by the European Society of Cardiology, they looked at the variance of the LPA, genetically determined, and how that impacts heart disease. And the more of the variance you have, the greater the risk of a cardiovascular event, as shown in the bottom line. One often asks the question, well, if LPA is associated with increased risk, how does it compare to familial hypercholesterolemia? In this analysis of Copenhagen Heart Study, where they evaluated individuals with the same geographic location, same ancestral background, they identified those who had heterozygous FH and those who had high LPA levels, which of course is a genetically determined lipoprotein not influenced by diet, weight loss, or exercise. And the equivalent LPA level associated with a clinical diagnosis of familial hypercholesterolemia is 149 to 868 nanomole per liter. For genetically diagnosed hypercholesterolemia, the average LPA level would be 338 nanomole per liter. So we can see that if we focus on this bottom line here, having an LPA level in the low 300 nanomole per liter puts that individual at the same risk as somebody who's got heterozygous FH in this longitudinal study from Copenhagen. Moving back to a summary of the EAS findings, both observational and genetic evidence supports that LPA is causal for ASCVD, aortic valve stenosis, and all-cause mortality in men and women. The relationship is continuous. The risk of ischemic heart disease and heart failure is seen at higher levels of LPA than seen with myocardial infarction in the aortic valve stenosis. What does this mean? That the association of LPA and myocardial infarction in aortic valve stenosis is stronger on a nanomolar per liter basis. There has been tremendous misunderstanding about LPA and impaired fibrinolysis. This is really an artifact of separating the A from the LPA, an ex vivo phenomenon, and the genetic studies have not shown that high LPA level is associated with venous thromboembolic disease. What about lipoprotein A and residual thrombotic risk in an evolving area? Well, there are individuals that have certain genotypes that put them at increased risk for platelet thrombosis. This was initially studied in the Women's Health Study, and then second in the ESPRIT trial. In this study, we can see that individuals who had these genotypes and a high LPA had increased risk of major cardiovascular events that was attenuated with the use of aspirin. So we're looking at 11.4 events per thousand compared to 3.3. And interestingly, these individuals had less bleeding complications on aspirin. So when we think about LPA-associated risk, at least where I practice, I'm able to send out samples for genotyping for this polymorphism. And in those individuals, I will place them on a low-dose aspirin to mitigate a 2.5-fold to 3-fold higher risk of cardiovascular disease. As I mentioned, this belief that LPA interferes with fibrinolysis was a lab artifact. This is data from Michael Boffa and Marlis Kloczynski, where they showed that if you have the A separated from the LPA, you can impair fibrinolysis ex vivo, but not for the intact molecule. And that's because the catalytic site for the impaired fibrinolysis is shielded in the lipoprotein form. LPA, however, does inactivate tissue factor pathway inhibitor, so a role with tissue factor. And this was shown that LPA and tissue factor pathway inhibitor co-localize in human coronary artery specimens. We contributed to the literature on thrombosis, where we showed associations between LPA, factor VIII activity, and CRP. In this paper from the REGARD study, we can see that individuals who have high LPA and high CRP and high factor VIII have the greatest risk of cardiovascular disease. The factor VIII activity is a positive acute phase reactant as CRP, but factor VIII activity links the inflammation to thrombosis. And the last time I was in Jaipur, I discussed work that's under peer review for tissue factor activity at the level of the mononuclear cell. What about therapeutic lowering of LPA? This is a question I had after the conference. What do you do for your patients with high LPA levels? Well, first of all, in the Odyssey outcome study, there's a concentration-dependent increased risk in major adverse cardiovascular events, CHD death, and non-fatal MI. Consistent with our data from REGARDS, the association between LPA and ischemic stroke is not as strong, and in this study was not significant. There were also non-significant changes in all-cause mortality, but this was a study that only had a duration of 2.8 years. But again, the strength for the coronary heart disease associations. In the Fourier trial, the higher the LPA level, the higher the risk of coronary heart disease events, the primary endpoint, and the expanded endpoint as well. And those individuals who were placed on a PCSK9 had a larger absolute treatment benefit, 2.49%, compared to individuals without an elevated LPA at 0.95%. And for the expanded endpoint, the larger absolute risk reduction, 2.41% versus 1.41%. So in other words, high LPA, higher risk, and greater treatment response to PCSK9 inhibition. We are now in the era of selective therapies that just lower LPA. LPA, again, is an ApoB containing lipoprotein that contains apolipoprotein A. And there are different domains on that A, known as Kringles. There are antisensitive oligonucleotides that are being tested, pelacarsen, small interfering RNA therapies, olpasiran, and then recent release of data on an oral small molecule inhibitor in a phase 1 study that works by disrupting the binding of ApoA to ApoB. With regards to pelacarsen, in this phase 2 study, there's a dose-dependent reduction in LPA of about 80%. These data led for the acquisition of this asset by Novartis and the launching of the Horizon trial, which is fully enrolled. And you know, the study's been ongoing for several years, and we wait for you know, the 4-year follow-up and to determine whether LPA lowering with this drug can reduce cardiovascular events. The small interfering RNA therapy, olpasiran, we were the global lead enroller in this trial, showed a much more robust reduction in LPA of about 95%, and it was again dose dependent. Why are you seeing more than 100% reduction over here? That's because of the increase in placebo, and these are placebo-corrected differences in LPA level. The fact is, striking reductions. This has led to the launch of the OCEAN(a) trial, which is randomizing individuals to olpasiran at a dosage of 142 milligram every 12 weeks versus placebo. The study is still enrolling patients, and we look forward to the complete enrollment of this study and then the results in years to come. Silence Therapeutics also has a small interfering RNA. The next steps on their program have not been announced yet, but they should be completing their phase 2 work. And then in terms of this recent discovery with muvalaplin, this is a schematic from data presented by Laura Michael at the European Society of Cardiology in August. And it shows that this muvalaplin over here disrupts the binding of the ApoA, the Kringle 4/8 domain with the ApoB, and this therapy is very efficient at low concentrations. The results of the phase 1 study were presented at the European Society of Cardiology and published simultaneously in JAMA, and basically there was about a 64% reduction in lipoprotein A. The assay they used captured free ApoA and LPA, you know, the A on the LPA, and because this therapy is you know, freeing up the A from the LPA, allowing for the clearance of the LDL particle, this approach may not assess the true efficacy of the therapy on LPA, and so other assays are being developed to more accurately capture the reduction of the LPA molecule versus that which is free, that gets degraded in the circulation. And so this therapy, you know, is promising as an oral agent versus, you know, the ASO siRNA, but in terms of moving on to next steps, that has not been announced. So to conclude, LPA is associated with coronary heart disease, aortic valve stenosis, but also stroke and heart failure in other studies. This is a genetically determined trait, not influenced by diet, weight loss, or exercise. It's associated with very early onset heart disease in some individuals. In men with coronary artery disease prior to the age of 50 years and women prior to the age of 60 years, a high LPA was common in 18.6%. This is why it's important to consider LPA screening, and if the LPA is high, cascade screening is also important to identify family members. Right now, we have no therapies that lower LPA selectively. One might consider a PCSK9 inhibitor, which has a quite variable effect on lowering LPA, averaging 25%, but some people have no response, some people have a 70% response. So one needs to evaluate the treatment response if you can get a PCSK9 approved for that individual. But we're really looking forward to the panoply of new agents, for lowering LPA, and also the future emergence of gene editing for lowering LPA, trials which may begin in about 2 to 3 years from now. Thank you very much.
Thank you, Dr. Rosensen, for your elaborative and in-depth talk about genetic basis of atherosclerotic cardiovascular disease, that is LPA involvement. And now I request Dr. Sajid Ansari, out of the turn, to deliver his talk. Till now we were deliberating about genetic basis now, and Dr. Sajid will tell about day-to-day use of metformin and NAD boosters, vitamins for the protection of atherosclerotic cardiovascular disease. Dr. Sajid Ansari.
Thank you, boss, and very good morning to all of you, and especially thanks to organizer and my mentor Raja Gupta sir. Our friends, very honestly, sir has given me today batting on a very tough pitch. When he allotted me topic for reduce the aging process and role of metformin in any way. So this was totally new for me. I mean, what is the way, and I am focusing my talk on this NAD metabolism, and we know from the physiology and biochemistry classes from cyclic AMP, PHMP pathway, and what the role of NAD. And if it is NAD is a supplement, or either we are going to prevent the degradation of NAD, we are having some positive effect. How is it possible? So this is my some thought-provoking question, that can we going to prevent the inflammation and aging process, and how to upgrade our life spans. So aging and longevity genes and the cardiovascular disease. We know in the NAD metabolism there is one key enzyme, that is sertraline. Deacylation is the one step, and by any way, if we are going to enhance the activity of this enzyme to promote the synthesis of NAD, or by any exogenous source, if we are going the NAD in terms of whatever we are going to use, the vitamins and all these things, I will come in the subsequent slide, we have some positive effect on this vascular endothelium and the cardiovascular system in terms of reduction of stroke, reduction of myocardial infarction, reduction of arterial stiffening, reduction of atherosclerotic process, and improvement in endothelial dysfunctions. And if it is we are going to effect on this, definitely we are having some better effect on the hypertension, heart failure, fibrosis, and the ventricular hypertrophy. So how to increase the sertraline activity? There is two ways. Either we alter the pathway of metabolism, or we go by the exogenous source. So different approach can be used to increase the sertraline activity, such as dietary intervention. Intermittent fasting, we know that's a very wonderful step in the metabolic syndrome, in the reduction of incidence, especially this hyperglycemia. Administration of NAD boosting sertraline activity compound, what is that? That is called a STAC. Common pathophysiological mechanism in cardiovascular aging and the longevity. This cardiovascular aging and longevity share underlying pathophysiological process. Prolonged cardiovascular health enhance the prospect of longer life. Longevity in a certain population is associated with the Mediterranean diet, reduced calorie intake, physical activity, smoking cessation, and advantageous genetic environmental factor. Region with exceptional longevity regard can be served as a valuable model for studying genetics and the pathophysiological mechanism for advancing field of rejuvenation medicine. We know this pathophysiological link between CV and all this metabolic process started from this various marker of inflammation and the effect on the vascular endothelium. So endothelial dysfunction and arterial stiffness, hypertension, and hyperglycemia, hyperlipidemia, hyperinsulinemia, insulin resistance, dyslipidemia. This all is the we are encountering in our day-to-day practice, and we are trying to improve it by either lifestyle modification or pharmacological intervention. But one thing is the important is genetics and epigenetic mechanism, that is to act on this telomere length of these chromosomes and DNA methylation and clonal hematopoiesis are intermediate potential. I mean, but this telomere length, and this is a clinical practice, this is a really challenge, and even I am trying to find out how to improve it in our clinical practice, in the day-to-day practice. So glucose metabolism and longevity, we know that insulin resistance is one of very important key factor. So anyway, if we are trying to reduce the insulin resistance by any means, and we know the magic field for this reduction of insulin resistance is lifestyle modification. We can't forget LSM. In spite of all this medicine, whatever is available for us, so LSM is the important one to go for the lifestyle modification, and if you are on the side of reduction the insulin resistance, we are going to prevent or at least check the atherosclerosis, decrease the aging process, and if we are not going for those, then we are going to increase the CV mortality and decreasing lifespan. If we are going to optimize this glucose metabolism in a diabetic and non-diabetic patient, so definitely longevity is prolonged and there is a reduction in CV mortality. This cardiovascular aging and longevity, this one, right span, this longevity, this is surprising. I get this article from the Google. There is a few population in the world, they are having highest lifespan, and maybe might more than the 100, that the average lifespan of this population. Loma Linda in this California, some population from Italy, Greece, Croatia, and Japan. So how they are able to get it? I mean, this is just a thought process, or really we can adopt in our practice. So that is some common pathophysiological link that we should be attacking the oxidative stress, check the inflammatory process, encounter abnormal glucose metabolism, attack on lipid disorder. We know the SLI guide and Lipid Association of India, lower better, and we should be attack on this LDL and arterial hypertension, arterial stiffness, and telomere shortening. So if we are going to do this, so delay the CV and may promote the longevity by some changes in modifiable risk factors, modifiable factor, that the Mediterranean diet, low calorie intake, exercise, smoking cessation, and drug with anti-inflammatory activity, calorie restriction, so and so. Favorable genetic background, I think this is a very important aspect of our field, that how to encounter genetics in our day-to-day practice. And believe me, I am from Lucknow, and if you need some genetic study for any kind of study, we have only one option, that is SGPG. I know one having to change, even if we are having patient of this hypertrophic cardiomyopathy, that is the only one place where we are sending. So this is a big challenge, so how to encounter in our day-to-day practice, and this modifiable and non-modifiable risk factor that favor this environmental conditions. So coming to what is the mechanism of metformin and how to get it in our day-to-day practice while using the metformin. Either can we get in the only benefit in a diabetic patient, or somewhere the pre-diabetic and some impaired glucose tolerance is there. So can we use the metformin, because I am discussing for this aging process. So suppose an old and frail patient is here, and even not frail, even some middle age, and he is non-diabetic. Should we start prophylactic metformin for check their aging process? So this is not recommended in the guideline, but there is some proposed mechanism that why this metformin is supposed to be future molecules. So metformin potentially reducing age-related diseases, promote decrease the incidence of IGF-1 receptor and insulin receptor activation. This triggered downstream effect, decrease pro-apoptotic effect, felicitate ROS detoxification inhibits cell cycle arrest and aid protection against the age-related disease. So metformin mechanism for eliciting similar effect. We remember the two important pathway, that is cyclic MPK pathway and inhibition of mTORC1. There are so many proposed mechanism, and some trial is also there related to this molecule. So, this Trela et al. And Lopez. So, and this is some genetic variation was observed with the different genes. So, difficult to remember in a clinical practice. But what effect they observe with the using this metformin? This affect the efficacy of metformin entering in the cell, and Lopez and Bermejo et al. Influencing both insulin sensitivity and metformin efficacy in hyperinsulinic gas with this androgen axis. So this kind of activity was observed by using this metformin. So target of metformin among the hallmarks of this aging process. So metformin attenuates the aging and aging-related disease by targeting 9 hallmark of aging. This is, different proposed mechanism: loss of proteostasis, effect on telomere, genomic instability, epigenetic alteration, deregulated nutrient sensing, mitochondrial dysfunction, cellular sensing, altered intracellular communication, and stem cell exhaustion. So there is some primary hallmark, and 3 are antagonistic hallmarks in the middle, and 2 are integrative hallmarks. So metformin is supposed to be a wonderful for upcoming days in this context. This other study and very busy slide, but ultimately they have tried to prove that they have the wonderful effect on this metabolic process. So overview of promise and safety concern of this NMN and anti-aging products. So NAD biosynthesis pathway in which NMN is involved. As I discussed in we have 2 options: either improve the synthesis of NAD, or either we go for supply of the NAD. So how to biosynthetic pathway is improved? The biosynthetic pathway of NAD plus in the mammalian cell in which NMN involved are Price handler and Solvay's pathway. That is a major source of NAD. That is a complex slide, and we read some on the biochemistry, so no need to read here. So causes of reducing NAD plus level, and when aging and mechanism for underlying anti-aging activities involves. So factor contributing to NAD plus depletion and DNA damage, chronic inflammation, oxidative stress, elevated NAD, and consuming enzyme. This is sirtuin is a very important enzyme in this cascade of this. So NAD plus decline, this lead to reduced energy production in the mitochondria, contributing to aging and the age-related disease. NMN supplement restore NAD plus level by biosynthesis pathway. NMN supplements has a potential to reverse the aging process and prevent the age-related disease. Cardioprotective action, if we are going to restore the nicotinamide adenine dinucleotide in terms of either by altering a synthetic pathway or exogenous supplementation. So practically we know when we are discussing the metabolic syndrome, always we are discussing about this reacting oxygen species, stress, inflammation level, ultimately some lead to some changes in the cardiomyocyte and the vasculoendothelium. And kind of FFF kind of things. So if cardioprotective action of NAD is supposed to be discussed in the this improve bioenergetics, decrease oxidative stress, decrease protein hyperacylation, decrease inflammatory process, and increase the autophagy. So ultimately, when in terms of you are going to see the number in terms of beneficial process, and this is so many literature article related to role of NAD in this. HFrEF and HFpEF patient, and improving the HFpEF, especially improving this hypertrophy and so many articles related to this causes relating the aging process and hypertrophic remodeling, ischemic, non-ischemic cardiomyopathy, decrease the incidence of heart failure, improving the some pumping capacity, improving this muscle strengthening also. So I think So coming to supplementation part, can we supplement different kind of vitamin? We know vitamin D, I have the huge plethora of activity, and it has somehow, once this was a tornado, adding statin and vitamin D together for reducing the atherosclerosis process. DHA and IPA is the one things. Magnesium has a very important role. Some conditional choline, we know that very important in the female. So choline, we should be think of supplementation of choline and taurine base. We know that the important one. Coming to other, this is a argotheanine. So argotheanine is found in the synthesized by mushroom and cyanobacteria. So we can supplement it. Pyroquinolones and quinones. So this has the one role to improve this longevity and in the aging process. Carotenoids is the one, and honestly, this is the I never, in my practice, I'm confessing here, I never believed to go for such a kind of supplementation of vitamin and expensive medicine. But after presentation, I have some belief that we should think of this. So carotenoid is the one of them. So thank you, this all from my side. And one words that after presenting my this all thoughts, how to see in our clinical practice, how to see NAD level. So ultimately, we should be think of marker of premature vascular atherosclerosis, and you should be focus on this. We can't see the NAD, so we can't forget that things and believe on that talk. Thank you, this all from my side. Yeah.
Thank you, Dr. Ansari, for a very nice presentation. One quick question about NAD boosters. So it is very easy to prescribe the NAD booster, but it is very difficult for patient to tolerate it, as side effects ranges from nausea, flushes, right up to the brain fog and phlebitis. So what is the best way to reduce the side effects, and what is the best time to prescribe NAD booster, morning or evening?
I mean, which booster you asking? Booster means what? Which kind of medicine? Booster means what?
Pardon?
Which kind of medicine you are asking? Supplementation?
No, how to
Energy
reduce
booster.
the side effects of NAD boosters.
You know, in the
And what is the best time to take it?
I
Morning
know,
or night?
this kind of medicine usually used by this people like they are working in the gym and para clinics, and we know their side effect using. But whatever therapeutic use of this quinolones and DHA, EPA and carotenoid and lycopene, so this medicated preparation is coming. Of course, nausea is the very one important concern. So usually giving if needed after the meal, so minimize its side effect. But how much this is effective in the clinical sense, there is some trial, but there is no recommendation from the guideline. So this is a more like, I mean, going to build up hypothetical things, and there might be one better future, especially what is mentioned in the genetics and epigenetics study for this related to age-related process. Thank you.
Thank you for enlightening us. Now next session is by Dr. Dheeraj Khurana.
Just a minute. Dr. Sajid is leaving just now, so we can give him a memento, please. Ruchi, can you do that?
Now next session by Dr. Dheeraj Khurana, lipid management for stroke prevention and management. So now next session by Dr. Kushal Madan, familial hypercholesteremia, diagnosis and management.
Good morning. I am Dr. Kushal, and I am representing Department of Cardiology, which is Sir Gangaram Hospital, which is headed by Dr. Sahani. And I am here to talk about familial hypercholesterolemia, diagnosis and management. And most of those things were covered by Dr. Rosinon. So I would like to come closer to the practical aspects of how to diagnose and manage FH in Indian setup, and would like to share our Indian data on the same. Now, familial hypercholesterolemia, as we all understand, is the common genetic disorder of lipid metabolism characterized by elevated LDL cholesterol and leads to the higher atherosclerotic risk. It is the common disorder, but it is not rare and we don't look for it. Often it is missed in the clinical practice. In this graph, we can clearly see that only 1% of familial hypercholesterolemia were being diagnosed in most of the countries, including the developed countries like US and Canada and Japan, till 2013. And after that, there was some awareness about the disease. And now in 2023, almost 10% of familial hypercholesterolemia cases are being diagnosed globally. Familial hypercholesterolemia, FH, in 1995, actually, Doctors Brown and Goldstein were awarded the Nobel Prize for discovering the LDL receptor. They came out with the concept of familial hypercholesterolemia, that whenever these LDL receptors are less, so the uptake of bad cholesterol is not there, and that is the reason we develop this disease. So FH can be categorized into two, heterozygous and homozygous. Heterozygous is when a patient gets it from one of the parents, and it is more common, 1 in 250 in population. And the heart attacks, the disease actually comes in at early ages, like in early 30s and 40s. And the LDL receptors are reduced in number. But in homozygous familial hypercholesterolemia, which is rare, 1 in million in population, the LDL receptors are actually not there. LDL receptors are missing, and the disease comes much earlier, that is in early teens and in 20s. And the younger population suffers the heart attacks of severe kind at an early age. But we must understand that FH is underdiagnosed and undertreated clinical entity. In this, we can clearly see that out of like around 45 to 50 million people are suffering from FH across the globe, and out of that, around 17 to 18 million FH patients are in Asia, and out of that, approximately 5 million FH patients are in India. Dr. Rosenon gave a detailed description about the genetic screening of FH, but I would like to discuss how to diagnose FH in clinical practice. Genetic testing, we know that it is of use, but as Dr. Rosenon also mentioned, the limitations, it is the screening and is not very specific as far as FH is concerned. The genetic screening is not very specific. So there is this Dutch lipid clinic network diagnostic criteria for familial hypercholesterolemia, which is mentioned in ESC guidelines as well. It is a score-based criteria in which, if we encounter, just for an example, if we encounter a young person with MI, and he gives us a family history of CAD, then we can give him a score of around 2 plus 1, that will become 3. And if we can find an arcus cornealis below the age of 45 years, he straightforwards get 4 points. And based on this criteria, FH can be categorized into definite, probable, and possible. And a potential FH is any score which is more than or equal to 6 on DLCN criteria is considered as a potential FH. And it includes all the probable plus definite cases. And he can be diagnosed as potential FH. Now, but this is for statin-naive patients. This DLCN criteria is for statin-naive patients. So the even in the European Society of Cardiology 2019 dyslipidemia guidelines, it is mentioned that anybody who gets the disease below the age of 55 in men and below the age of 60 years for women, LDL cholesterol is more than 190 milligram per deciliter. In all those cases, they are a carrier of that FH gene and should be treated with a high dose of statin plus minus ezetimibe, and the target should be, the goal should be less than 70 mg, or in the presence of CVD, it should be less than 55 milligram per deciliter. Even PCSK9 inhibitors can also be used. I think I've missed something which is very important in these slides. I wanted to share that, just give me a minute to go back on this. I'll elaborate it here. In fact, that slide is missing, it seems. I said that this DLCN criteria is for statin naive patients. So we have a correction factor also available, in which, like mostly when the patient come to us, they are already on statins. So there is a correction factor available. Like if a patient is with coming with an LDL of 110, and he is already on atorvastatin 20. So the correction factor, there is a table for all the doses and all the drugs. It will be like 110 multiplied by 1.8, and it will come around 198. So that is the level of cholesterol when initially he was diagnosed. So on that level, that is more than 190 LDL, we can fix him, like we can diagnose his FH based on the DLCN criteria, and he'll directly get the score of 3 because his LDL level initially was more than 190. So this was the point I wanted to make here, but somehow that slide is missing. And cascade screening, as mentioned by Dr. Rosenon, is really very important in cases of FH. The cascade screening can identify the siblings and the children of the index case, and obviously the early management can prevent the premature CAD. For cascade screening, only criteria is a lipid profile. Lipid profile is simple and effective alternative for genetic testing for cascade screening of FH patients. And if we have an index case with definite or probable, that is more than or equal to 6 DLCN score, with an LDL of more than 115 children and more than 116 adult, we can straightforward make a diagnosis of FH in those cases. And as far as the management of the carrier of FH is concerned, statin therapy is safe in children. It can be started with low dose, but whenever a lifelong treatment is under the consideration, then genetic testing is desirable before we start the treatment. So by diagnosing a case of FH, we do not identify just a single case, but we can identify a family at risk. This is just to summarize the diagnosis of and treatment. If there is a young CAD patient, we can apply the DLCN criteria, and if he gets a score of more than or equal to 6, pharmacological management can be started with a high dose of statin plus minus ezetimibe or bempedoic acid. And if the LDL goals are not achieved, PCSK9 inhibitors can also be started. But simultaneously, the treatment will not be considered complete if we do not do the cascade screening of the family members and the siblings. So on cascade screening, if we find, we do a lipid profile, and if we find that the LDL levels are higher, more than 150 in children and more than 160 in adults, we can start the low to moderate dose statin, and they will be considered as carrier of FH. Now, I would like to just share a few research which we conducted at our hospital. We conducted a study to find out the prevalence of FH in premature CAD patients in our hospital, in patients coming to our hospital, and we found out that it is around more than 15 to 17% of young MI are diagnosed as FH. Around 17% are diagnosed as FH. And another important finding which we found, that if a young comes with an MI and he doesn't have any risk factors, so we should think of FH. in this graph, we can clearly see that the people with definite FH have have no risk factors, and people who have risk factors, they have no FH. So if we have encounter a young MI with no risk factors, we should suspect FH. One should suspect FH in young CAD with elevated LDL and without risk factors. We also conducted a study on cascade screening in genetically confirmed FH patients. And this was a study in which we involved around 100 patients, and we did the mutation analysis for LDL, ApoB, and PCSK9, plus the lipid and genetic cascade screening was done for all the positive cases of FH mutation. And in this study, we found that out of 47, 43 had LDL mutation positive, 2 had PCSK9, and 2 had ApoB mutation. And out of those 43 cases who were LDL positive mutation, we conducted a genetic studies for their family members also. There were total 134 family members of mutation positive index cases, and out of those 134, 95 had family specific mutations, and out of which 15 had CAD and 80 new cases for primary prevention were identified from the family members. And out of those 95, 16 family members were less than 18 years of age. So this is the same slide, I think, which Dr. Rosanen also shared with us. So I would like to skip it here. And this is one of the studies which was published in New England Journal of Medicine, which showed that the 20-year of follow-up of statins in children with FH was found to be safe and effective. We also were a part of a study in which the evolocumab in patients with homozygous FH was studied, and it was found that evolocumab was safe and well tolerated in patients with homozygous FH in India with smaller reductions in LDL-C and other lipids. And at Sir Gangaram Hospital, we are also a part of the global European Atherosclerosis Society Familial Hypercholesteremia Registry, in which around more than 69 countries are participant, and the total enrollment is already more than 61,000. So we are part of this registry. And just to conclude my slides, FH is the most common metabolic disorder despite significant health risk. It is inadequately diagnosed and managed. FH is not rare, we miss it. And DLC criteria is a simple way to diagnose FH clinically. One should suspect in patient of premature CAD and LDL more than 190. Cascade screening using lipid profile is most effective way of preventing premature CAD in the population by starting early statin therapy. And in our study, we found potential FH in approximately 17% patients of premature CAD. High-dose statin with or without ezetimibe is adequate in majority of patients. PCSK9 inhibitors may be required in 5 to 10% of heterozygous FH patients. Thank you so much.
Sir, one quick question.
Yes.
Many young individuals coming in the OPD with no previous significant past history, no family history, with LDL cholesterol between 190 to 200. How we will evaluate these kind of the cases with no significant past history, no clinical symptoms, and there is no tendon xanthomas, anthelisma, nothing is there. How we will proceed in these type of cases?
Definitely, we will start with the statin therapy, and if possible, we would like to go for a genetic testing as well.
Because these are the very common situations we are encountered daily in routine practice.
Yes.
So how we label primary hypercholesteremia, familial, or diagnosis uncertain, only hyperlipidemia?
We'll apply the DLC criteria, and based on that, we can categorize him as a definite or probable or maybe a possible case of FH, and accordingly we'll proceed. So the first step will be to apply DLCN, calculate the scores, and accordingly proceed with the pharmacological and the lifestyle management.
Thank you, sir. Thank you.
I think we have one question. Only one question allowed.
Okay, thank you. Very nice presentation, and I'm wondering about the genetic diagnosis part of it. Where are these genetic tests available? And are you able to get
yes.
SNPs and various other alleles identified as well?
Yes, in India, these genetic testing is actually available at our setup, definitely. But we routinely do not go for genetic screening as it is. I do understand that it is not readily available and expensive too. So, but yes, we are fortunate that we have this screening available at our setup.
Is it not possible to collect some samples and partner with some labs elsewhere to get some of those? I'm just wondering that, as you correctly pointed out, that the diagnoses are being missed, and there may well be additional novel SNPs and variants that we probably ought to know more about.
Yes, probably.
talk
I
about
think
that later.
I would like to discuss it with my head of the department and Department of Research, that possibility of collaborative testing is possible. I think I need to discuss it with my seniors first.
Right, you already have a big registry,
Yes.
so you do have,
Yes.
a network.
Yes. Thank you.
Thank you so much, Dr. Kushal. Next, we'd like to invite Dr. Dheeraj Khurana, and we will be discussing about the lipid management for stroke prevention and management.
You have a pointer? Yes, I will. Thank you, Chairperson, for introducing me. And first of all, good morning, everyone. And I would really like to thank Dr. Rajiv Gupta for having invited me here. It's a meeting which I think is important from the perspective of neurologists, although what we in neurology often say that what cardiologists have been doing all these years, a few years later down the line, the neurologists start following it. But this area, I would say, is a major field or the cornerstone of lipid management, and is more often undertreated or overlooked. That's a very common observation. And I'm quite vociferous about the fact that we should treat them aggressively for lipid management. And this is one area which, like I said, is highly untreated. And I see this with both my neurology colleagues as well as cardiology colleagues for the undertreatment. Excuse me for saying that, but that's an observation. So what do we know? I'm not going to go into the basics of lipid management, the stroke management and stroke statistics. We know it's one of the highest causes of death, number 3 in the world, or number 2 in the world, variously in different statistics, and the leading cause of disability. And lipid management, like I said, plays a pivotal role in the management of both primary as well as secondary preventions. Now, importantly, we've had some interesting lectures in the morning on PCSK9 and LPA, and that's one area which, apart from LDL, not many people are looking in neurology, whereas LPA, size particles, etc., I think play a very important role and are going to play a very important role even for stroke, as was pointed out in the morning lectures. So we defined dyslipidemia. I think that's pretty well known to everyone. Now, in stroke, the fact that we know lipids have to be treated, despite those facts, there are a whole lot of unknown areas or areas which are not very clear, which raise a whole lot of questions. And I think that is one of the reasons the undertreatment happens. So let's look into the evidence today and where do we stand as far as treatments, and on those areas, the gray areas where things are not clear. So what is known clearly is that lipid and lipoprotein biomarkers have an association with cardiovascular disease, which includes MI and stroke. That's absolutely clear. LDL-C lowering, we also know, reduces risk of ischemic stroke. Number of meta-analysis, huge number of trials. But we go into the details of what exactly is entailed by lowering of LDL. And also aggressive lowering, which was first initiated in the trial, which was specifically targeting stroke, the Sparkle trial, the well-known trial in 2006, does reduce the incidence of a secondary stroke. So these are big gross things that we know about stroke. What are the unknown or unclear things? A major unknown thing is it beneficial across all types of strokes? For example, a large artery stroke, which is atherosclerotic in nature, versus a small vessel disease, or a cardioembolic stroke. So in our field, it's very important to know the reason why the stroke has happened. It's not all strokes are the same. And the secondary prevention is targeted according to the mechanism of the stroke. So what we know is statins or LDL lowering is likely effective in large artery atherosclerotic disease. Elevated lipids in small vessel disease is scant, and we don't really know whether lowering of LDL in small vessel disease is beneficial. And the other part is the role of HDL and triglycerides have causally never, they have not been implicated by evidence. So we don't know their role. However, we know that HDL increase in HDL is beneficial in small vessel disease. So let's look at some bit of discussion on what do we know about the lipid subfractions and the stroke subtypes. Now, studies conducted, this study which I'm quoting is done on a Mendelian randomization study, which looked at through the GWAS. So this basically looks at the genetics of the various subfractions and associates them with the subtypes of the strokes. So a high LDL-C with large artery atherosclerotic disease, like I first mentioned, is well established, easily seen in this graph. There's a clear-cut indicator towards association with a large artery. The rest don't seem to be very clear. LDL-C does not seem to be associated with small vessel disease. So this is one fact which is emerging in multiple studies and huge meta-analysis. However, an elevated HDL-C seems to be associated with low risk of small vessel disease, which is quite interesting and may be cardioembolic, but the robustness of this evidence is more for small vessel disease. So if you have high HDL, probably you have, we don't need to target LDL possibly in small vessel disease. And if we look at primary prevention, how can lipids be used in primary prevention? We know that there are a huge number of risk factors as indicated in this graph. These are most of the risk factors that we talk of: physical activity, apolipoproteins, diet, etc., etc. And most of the stroke risk is accounted for by these major 10 vascular risk factors. However, lipids do play a role, and statins can be effective for primary prevention of both acute coronary syndrome and MI, but how much of role ischemic stroke it has in ischemic stroke is again very unclear. However, a number of studies have emerged which tell us about the role of primary prevention. And along with the reductions in fatal, especially non-fatal MI, cardiovascular disease mortality, non-fatal stroke reductions have been noted. So what is non-fatal stroke? So that may be a smaller stroke which didn't lead on to death, because but that's important because all of these non-fatal strokes who survive have a very high incidence of MI in the future, and that's been found out. So risk reductions with statins do affect the non-fatal strokes. That's what's been found. And the absolute benefit of statin is actually proportional to the absolute risk of the vascular risk. You're having a generalized vascular risk, so strokes also get affected, and absolute reductions in LDL, which we've seen in a number of studies. And what has also been found is for every 1 millimole reduction in LDL, you reduce the risk of the first stroke by 21%, which I think is not small. So LDL reductions in patients who have high LDL does act as a very good deterrent to prevent a stroke. So the risk reductions for the major events can be also calculated per mole, per millimole reductions, or 38.7. Per millimole reduction LDL cholesterol level is 0.77 for all vascular if you use statins, and if you use non-statins it's 0.75, not major difference. Now another big thing which harps on the mind of people is the risk of ICH. That comes up often in discussions. If we are giving statins, are you going to increase the incidence of ICH? Now let's go into this narrative. Meta-analysis done in back early to 2000s. This did show that the lipid-lowering therapy was not associated with significant increase in ICH in both primary and secondary prevention trials, as we see in this meta-analysis. So this is basically the diamond, the strength of the diamond, you know, the size, what it shows for both primary and secondary prevention lists down. So there isn't really a major risk which is seen on either side. However, one of the important trials, the TNT or the treating to new targets, used atorvastatin, high dose versus low dose in IHD, and what it found was a 25% reduction in relative risk with more intensive treatment. So one is for sure that we have high intensity statin treatments do reduce relative risks of stroke. And I think the slide on ICH got, so I'll just take the ICH slide first. So like I said, ICH and hypocholesterolemia. So since this discussion started that there may be some risk, and it actually started from the Sparkle trial. So in the Sparkle trial, high dose statins were used, but it also showed not only risk reduction in strokes, but a slightly high increase in the incidence of ICH. However, beyond the Sparkle trial, number of studies which carried out have shown both meta-analysis, and we don't currently have trials, but we have population studies which have shown that an increase in LDL has been associated with 3% lower ICH risk. So one of these studies, which that means if you have a higher LDL, you have a lower ICH risk. So that only indicated that there may be a risk if you reduce the LDL. However, and this was more pronounced in Asians, likely because Asians had higher intracranial disease. And also it was found that reduced lipids could be an independent risk factor for cerebral microbleeds. However, Sparkle triggered off this thought that you are reducing LDL and increasing ICH, but later on, a lot of meta-analysis, huge meta-analysis on trials, and even the conglomeration of case studies did not show any increased ICH risk post-Sparkle trial. And this population-based Swedish study also looked into statin use before ICH and was found that there was no increase. In fact, there was a decreased ICH risk. So this entire story around ICH may not be entirely true. However, it is still believed if intensive lowering may possibly have, which was done in the Sparkle. So if you're not doing an intensive lowering, statins may actually reduce ICH incidence. And hypercholesterolemia, so it comes to the fact, appears to be a risk factor for ICH, hypocholesterolemia. However, this is possibly though in those patients who have other risk factors like hypertension, and statin use should not be discouraged. It does not appear to increase ICH in normal population, and in fact, this is what we need to remember, that we need to treat normal population if there is high lipids in these patients. So looking at the secondary prevention studies, 3 major studies have been carried out. First one was a heart protection. So heart protection obviously was carried out primarily in cardiac patients. However, the heart protection sub-study showed a 20% risk reduction and 5% absolute reduction of vascular events. Sparkle, I've just mentioned, it showed, although a good reduction in stroke. However, hemorrhagic strokes were common only in those patients who had hemorrhages in the baseline, because Sparkle included patients with hemorrhagic stroke, not just ischemic strokes. The French-Korean study, the target to stroke treatment used 2 different doses or targets, intensively lowered targets and moderately lowered. So their targets were either less than 70 or 90 to 110, and those with high reduction did have low risk of CV events. So we know that other meta-analysis carried out has shown that intensive favors recurrent stroke risk. However, a hemorrhagic risk is also there with intensive lowering. So that is one thing that may be avoided. The biggest fact which emerges is the presence of atherosclerosis. A lot of these studies looked into the fact that if you had extracranial atherosclerotic disease, that is atherosclerosis anywhere in the body, those were the patients who actually had more benefits with statins in stroke. So if you have a patient with large artery atherosclerotic disease or atherosclerosis elsewhere in the body, more intensive lowering statin-based therapies are mainly the effect is restricted to these patients who have evidence. Whereas if you do more intensive statin-based, although they're associated with reduced risk of MACE, ischemic stroke, and MI, there may be an increased risk of hemorrhage, and these with multiple risk factors. This I just talked of. We all know about the major risk factors or the major high-risk patients. That is number of, as the risk factors keep increasing, you call them high risk, and guidelines clearly state the benefits of lipid lowering in these patients, especially if you have very high-risk patients. The lowering has to be intensive, and ezetimibe may be added, whereas in patients, for those patients with no known coronary heart disease, LDL cholesterol more than 100 is, we should have atorvastatin at least 80. So intensive lowering is indicated by all the guidelines. I would skip this. And as an algorithm for secondary prevention, patients who do have either a history of stroke, firstly we give lifestyle and look at the LDL-C. If there is, has the targets been achieved? If not, we of course try to achieve targets by higher doses, add ezetimibe, and then go on to add PCSK9 if the targets of LDL-C are not achieved. Same for primary prevention. We need to look at the risk, whether it's low, moderate, high, depending upon the cardiovascular risks the patient have. And these are basically just a tabulation of most of the risk factors, and LDL particles are emerging into the utility for looking at the risks. And number of treatment options available are experimental. Currently, we have use of statins. For LPA, still more experimental, but a lot of trials in stroke are coming up. Can skip this. So this is the last slide. We do have now riskometers. This is the WSO riskometer available to use, and this provides a very practical way of determining your risk for stroke in the next 10 years. One should use it. It's available on the website of the World Stroke Organization. And to conclude, most of the recommendations do endorse lipid lowering for stroke prevention, both primary and secondary, and we should resort to statins, and PCSK9 in the future may have in stroke. There are a few trials already available. Lifestyle changes are mandatory, should not be forgotten. And this integration of lipid management is, I would say, essential, mandatory, and should be really sought aggressively to prevent another stroke. Thank you.
Sir, this is time for the session. Should we continue? There are 2 remaining talks. Should we continue? Next talk is by Dr. Soumitra Rai about lipid management in type 2 diabetes. Dr. Soumitra Rai, welcome.
Good morning. Thanks to respected chairpersons, and a big thanks to the Rajasthan chapter of CSI for calling me for this occasion. Second World War was perpetuated by whom? Hitler, Mussolini, and Tojo against humanity. So if we think the new Third World War is being orchestrated by hypertension, diabetes, and dyslipidemia against humanity, then we have to remember who antagonized and who actually stopped those trio. Those are Roosevelt, Churchill, and Stalin. So in today's world, we need anti-hypertensive, anti-diabetic, and Stalin and statin are so similar sounding, I think they fit for each other. So statin is there to challenge the new Third World War. Today's topic is lipid management in type 2 diabetes, and if we see the appalling picture of International Diabetic Federation, the key information in diabetes in India 2021, I can't really count that total adult population, and 8.3% have got diabetes. And you see the state-wise, I am from West Bengal, one of the bad states affected, but you see in Rajasthan is actually good. Rajasthan is good. Very bad are certain prevalence in certain countries as well, certain states like UP, Madhya Pradesh. So what is the overall prevalence of diabetes? A large-scale Indian Council of ICMR India Diabetic, you know that that is a very big project of 16,000 odd diabetic adults. I'm talking about diabetics only, revealed increased risk of high cholesterol by 2.47 odd ratio. High triglyceride is the highest, 3.41, low HDL 1.78, and high LDL by 2.39. And if you see zone-wise, if you see northeast, west, and south, there is similarity, but there are subtle differences of how this LDL, HDL, and triglyceride behave among the zones. Almost 90% of Indian diabetic people have got some form of dyslipidemia. Hardly you get 1 in 10 people who have fulfilled all the 4 criteria in the normal range of LDL, HDL, TG, and maybe total cholesterol. So what is atherogenic diabetic dyslipidemia? It is characterized by a triad of high TG, of low HDL, and more or less normal LDL, but small dense LDL is high. So that is a notorious triad, as I mentioned before. And if you see triglyceride and HDL dyslipidemia and risk of coronary heart disease, the strong heart study, you will see when both are bad, high TG with low HDL, that is almost a double the mortality if you have both in the normal range. And I think it has been elaborated in the morning session that LPA is a big risk modifier in diabetic patient. Both coronary artery disease and diabetes risk increase as the LPA increase in our body. So you see there, this is a very nice slide showing the diabetes specific risk enhancers. One is duration of diabetes, one is albuminuria, low EGFR, retinopathy, neuropathy, and ABI below 0.9. These we usually do not look or consider as risk factor in a non-diabetic person, but these are special risk factor for coronary disease in a diabetic population. And if we see, as I said, serum cholesterol and cardiovascular disease mortality, men with and without diabetes, if you see long time ago, it was published 30 years ago, MRFIT trial, which clearly showed diabetic people at every range of cholesterol had got 3 times more cardiac mortality. But that also increases with the cholesterol level. So the graph remains same, only at a higher level. And if we see the STENO-2 trial, intensive therapy of multiple issues like lipid profile, like blood pressure, and like sugar, if you control 3 together, then only you can stop the World War II. Otherwise, by killing one person or stopping one country, either Japan or Germany or Italy, you cannot really halt the World War II. You have to control them together, and that's how it was shown in the STENO-2 trial. What is non-HDLC? Nowadays, it's very much a hyped up thing. We are checking non-HDLC. Actually, it is nothing but all cholesterol excepting HDL cholesterol. They're all bad. So as a category, they are all Kauravas. And the Pandav is the HDL. So all the Kauravas together don't identify Duryodhan or Dushashan differently. They are all together, all the 100 boys are on the same category. So whoever is not Pandav is a Kaurav. And that is the non-HDL. That is a simple concept. Don't confuse it with anything else. And its goal is 30 above the LDL. So Duryodhan alone is the everything. All the other 99 Kaurav becomes more 30. So LDL plus 30 is your goal for non-HDL. Non-HDL is definitely cardiovascular risk. They have got their own nuisance values, all the fractions. And my job has become made easy, I don't know why, by ESC guideline just published last month at Amsterdam. And they have got the first time came out with cardiovascular disease in patient with diabetes, a new guideline. So that's fantastic. It is a fantastic guideline. If you go through it, they have done everything. So if a patient comes with a cardiovascular disease, you go out to check whether he is diabetic. If he comes to you as a diabetic, then go out to see whether he has got cardiovascular disease or chronic kidney disease. These three have to be excluded if one is present. Otherwise, you are not excused as a clinician. So a person coming to you as a heart disease, you must see his kidney status and his diabetic status, and vice versa. And if there is diabetes, cardiovascular disease, kidney disease together, you know what to give, GLP-1 receptor agonist or SGLT2 inhibitor. And very new is finerenone in diabetic kidney disease, not yet in heart failure. So cardiovascular risk category in type 2 diabetes, you know, ESC has given a very nice guideline, but here it is a diabetic subfraction. In diabetic subfraction, who is very high risk? A diabetic patient with ASCVD or target organ damage or 10-year CVD risk of more than 20%. And there is high CVD risk and moderate CVD risk, and is there anyone called low CV risk? Patient with diabetes not fulfilling any of these criteria. So these are the categories, and depending on that, there is a score 2 diabetes setup. You know, the score 2 risk factor is a risk assessment category or riskometer, as was said, for general population. But for diabetes, there is a separate subsegment of score 2. And here, if the ASCVD risk of score 2 is more than 20, it is very high risk. 10 to 20% is high risk. 5 to 10 is moderate, and below 5 is low risk. That is a new algorithm that has been published very recently. And in very high risk, your goal is below 55. In high risk, it is 70. In moderate risk, 100. But this 55 is being challenged from Lipid Association of India. They are talking about 30 in certain specific group. And I just saw that last week in America, Professor Bartz presented the American Lipid Association guideline. There also they have taken up the 30 as a cutoff in very, very high risk population. So it is always controversial, and you can always argue. And then, of course, you need statin, statin, and statin. So if a examiner asks a person in an examination, what do you give for dyslipidemia and diabetes? What is the medicine? You say statin. What is the second medicine? Statin. Third medicine? Statin. Do you have anything else in your basket? Yes, sir. I have got ezetimibe, I have got bempedoic acid, I have got PCSK9, and from November end, I will have inclisiran. So life is simple. You don't have to remember anything, as long as your patient can afford. That is the only thing. So CHD prevention trials with statin in diabetic patient, they're all very old style. Primary prevention, secondary prevention, primary, secondary combined. Everywhere there is a diabetic subgroup. And if you see the diabetic subgroup, the enhancement or benefit by statin is more than the general population. So though we know that statin causes diabetes, there is no argument about it. Statin causes 5 to 10% increased risk of diabetes. But to give statin, because even if it causes diabetes, it will prevent the mortality in that diabetic person. So statin therapy is only class 3 in premenopausal patient with diabetes who are considering pregnancy without adequate contraception. So statin is teratogenic. So statin cannot be given if somebody is thinking of even pregnancy, let alone trying about it. So what do you do in the pregnancy diabetic with dyslipidemia? You pray to God every day, you do the lifestyle, you check your diet, and you give niacinamide, that is somewhat effective, and maybe 1 or 2 plasmapheresis, but basically tide over those few months. So, but statins does not work equally in metabolic syndrome. This is my paper published 3 years ago, and I could find out by meta-analysis that atorvastatin, pitavastatin, rosuvastatin, simvastatin, they have got difference in new onset diabetes. Actually, pitavastatin is protective, whereas rosuvastatin is most active. Triglyceride reduction also varies from statin to statin. HDL increase also varies. And if you see metabolic profile-wise, pitavastatin is the best, but unfortunately its potency as LDL lowering is actually very modest. So summary of dyslipidemia in metabolic syndrome and type 2 diabetes, you see, and there is an RSSDI also has published their guideline. TG is very important, we know, because there is enough data that triglyceride, if not controlled, can cause further cardiovascular event, even when your LDL is absolutely controlled. And mechanism may be that triglyceride increases small dense lipoprotein. Though it is not very clear, but it has shown that the same level of LDL is more atherogenic if it is associated with high triglyceride. So that is a study published long ago, and I think it's a fantastic study when it showed that as triglyceride increases, the small dense LDL increases disproportionately. And we have shown that if TG is high and LDL is low, fibrate works. But fibrate is a dangerous drug. It causes rhabdomyolysis and nephropathy. Fenofibrate may be combined with statin only if the benefits are very high. There is renal status must be closely monitored. You cannot give it if the eGFR is below 30. And between 30 and 60, your dose should not exceed 50 milligram per day. REDUCE-IT trial showed that the omega-3 fatty acid works, and works too good. You see how many zeros are there. I haven't seen in any other trial under the earth so many zeros. And I don't know how Deepak Bhatt brought out. He himself became very ashamed of these p-values because it is not feasible. With all the all modern medicine, you cannot reduce a cardiovascular endpoint by 0.801 by giving omega-3 fatty acid. And of course, that has been negated by the strength trial. But again, there is claim that eicosapentaenoic acid per self is good. When you add docosahexaenoic acid with that, maybe the good effect of eicosapenta is gone. And eicosapentaenoic acid has just been launched in India. So it's up to you whether you use it or not. It will stink a lot. It will give atrial fibrillation. It will cause diabetes. It will increase body weight. And if the fish-eating communities, like we Bengalis fish eating, Deepak Bhatt himself said that, Ray, I do not know whether you eat fish, whether you will get extra benefit from this omega-3 fatty acid. So we do not know. And actually, I saw a preparation yesterday, sir, in your dinner, Marwari fish curry. I didn't understand the meaning of it because I thought Marwaris do not take fish. So what is Marwari fish curry? But again, then the fish-eating population are perhaps more protected. Anyway, pioglitazone is very good. Also, it is coming up, but you do not use it to reduce. And of course, we have got our saroglitazone in India, which is good to reduce triglyceride, and it is safe, but no event has been shown. So this is my last slide. Dyslipidemia ADA 2023 said that intensify lifestyle therapy, optimize glucose control, triglyceride should be below 150, HDL should be above 40, and lipid profile should be done at the time of diagnosing diabetes and initiation of statin as soon as possible. This is perhaps the future 30, 50, and 70 instead of 50, 70, and 100. Thank you.
Thank you, Dr. Somit Rai. Because of lack of time, we will request Dr. Sanjeev Gupta for his next talk, that is gene therapy in familial hypercholesterolemia and other cardiometabolic syndromes. Dr. Sanjeev Gupta is a doyen of his field and he is son of soil. He is presently in US and very eminent personality in its field. Thank you. Welcome, Dr. Sanjeev Gupta.
Thank you very much. It's a pleasure to be back again. And I see all the diehards are here. But many years ago, we were thinking about gene therapy as the penultimate kind of a solution. And now we've begun to make a full turn around, and we've begun to think about this even as the first-line therapy. So that is quite remarkable. And I thought what I'm going to do today is to talk about these relatively straightforward areas. What is the framework of gene therapy when we think about gene therapy? What does that actually mean? And what truly is the potential of gene therapy in terms of therapeutic outcomes and the limitations? I'm not going to talk about cost as a limitation, but that, of course, will be an important consideration, especially when we begin to think about applying it to large numbers of people, hypercholesterolemia, other than the rare condition of familial hypercholesterolemia. I don't think it's really practical because of the cost factors. And then philosophically, partly, and partly mechanistically, what are the forks in the road that we are currently forced or otherwise from a proper experimental design taking? So those are the areas that I'm going to focus on. And obviously time is limited, so I'm going to be somewhat superficial in some ways, but hopefully we can have some discussion later on. Now, when we talk about gene therapy, there are two broad forms of gene therapy that are known technically as ex vivo or in vivo. So what ex vivo means is that one takes cells out, transduces them, and then transplants them back. They could be autologous or allogeneic, and then there are restriction points in that process, which include the cell viability, because if they are not highly viable and if primary cells are taken out, as for liver-directed gene therapy, then we are talking about hepatocytes predominantly, not solely. Then if the initial viability is not good and if they have to go through a step of cell culture, and when they are then harvested in that process and if the viability declines further, those become restriction points. And we'll look at an example of how that gets done. And what in vivo gene therapy means is that one takes a vector, a synthetic sequence as well. We have heard about that, and we'll see some more of that as an example. And then it's a matter of putting that back directly into the body through intravenous injection or other means. And then the idea is that one would need to target that to a specific cell type, say hepatocytes. And that is done in one of very many ways. But if that targeting is not good, and if there are, say, additional immune responses associated with a vector, adenovirus vector, for example, or adeno-associated vectors and others, then that becomes a problem as well, which has nothing to do with transgene correction, etc. And the biological mechanisms come into play because if you think about a cell that may have a diploid genome, a healthy genome with 2 copies of chromosomes, versus a cell that may have a replica, multiple genomes in a nucleus because of polyploid change. And that's an inveterate part of hepatocyte biology, that there are endoduplication states. So one may have not just 2N diploid, but 4N, 8N, 16N, meaning multiple genomes. Then could all of those be corrected by any approach that one might take or not? And if that does not happen, then there could be restriction points related just to that biology as well. So that's important to keep in mind as well. Now, there are certain critical outcomes for a gene therapy, and I've modeled them here. That first, gene transfer must be efficient. If we have to have a large amount of a therapeutic protein or construct going into cells, there need not be a huge amount of that correction for proteins that are required in small amounts, such as, say, coagulation factors, factor 8, for example, or factor 9. And then the modified cells must assume a certain amount of mass if it's an ex vivo approach, or if it's an in vivo integrating genome-based approach. And then the transduced cells must then continue to survive and retain that transgene function as well, editing or otherwise as well. And so one can then model these kinds of processes in several different ways, and these modelings come from our and other people's work in liver repopulation by putting in known fractions of cells, transplanted healthy cells, and then to find out how much of that will survive under these different conditions. So if there's extensive liver replacement, then we would say a success would be guaranteed. And on the other side of the spectrum, in model D, where there is attrition of all those transduced cells, then that would guarantee failure as well, and somewhere in between. So these are the ways one thinks about conducting gene therapy studies or developing vectors and other components as well. Now, the rationale for different components of a metabolic syndrome comes from specific disease states. We had a prolonged session yesterday about the steatotic liver disease, or currently, as we call it, fatty liver disease as well. So here we know that hepatic lipotoxicity and inflammation are important pathophysiological mechanisms. And we are building up associations between gene variants and disease phenotypes. And one of these variants that has recently been identified is called PST3. It's a mouthful for the gene name, so I'm not going to say it. It's written over there. But this variant, this gene, this allele is involved in lipid handling. And through a subtractive approach, investigators from AstraZeneca found that the allele here contributes to protection when this is mutated. So anyone who does not have normally functioning gene is protected against fatty liver disease. And so then they went on to downregulate this allele in various model systems, in vitro and in vivo mouse preclinical studies, and they found that this was one way to decrease steatosis. Not the full spectrum yet, these are early days, but that's one example where through a personalized medicine-based approach, a susceptibility gene variant could well be identified and targeted in this way. There are monogenic disorders that contribute to fatty liver disease and other liver injuries as well, and Wilson disease is one of these examples where there is ATP7B transporter deficiency, and that leads to copper accumulation. So there are two of these studies going on for gene therapy. Two trials are going on with I think it's got a mind of its own now, for AAV vectors, and we are waiting to see how they will come about. The idea is that there is a deficient phenotype here, a lack of ATP transporter, and the idea is that a transgene will complement or replace that deficiency. But with AAV vectors, there's a huge immune response related to either inability for gene transfer to begin with, or during gene transfer. So just this week, we found a case of Duchenne muscular dystrophy where there was a death because of a cytokine storm following AAV transfer. It's not necessarily benign vector that way. Hypertension, surprisingly, has become a candidate as part, I suppose, of metabolic syndrome for gene therapy as well. And here the idea is that angiotensinogen, which contributes to hypertension, can be downregulated through an inhibitor RNA approach. And so there has now been completion, in fact, of a phase 2 trial by Alnylam Pharmaceuticals with the interim results that were just presented last week, or this month, I should say, earlier in the month. So that's interesting, and the outcome here was about 15 millimeters mercury decrease in systolic and also diastolic less than 15. But the idea is that this would improve compliance, and a person would not need to take medicines daily. It's a less frequent treatment. And then cholesterol, with including familial hypercholesterolemia, is the idea that it's one and done kind of thing. That's the favorite phraseology nowadays for anyone who is doing this kinds of permanent treatment. And I'll walk us through one of the couple of things. So way back, we set up the principle for treating familial hypercholesterolemia, where in collaboration with Jim Wilson and using the Watanabe rabbit model, we showed that the basis for LDLR correction was indeed in hepatocytes, first by transplantation and then by the ex vivo gene therapy approach. And using a retrovirus vector, then we were able to establish that based on the amount of liver repopulation, we could have lowering of blood cholesterol. And this then led to a clinical study as well. So that was really the first such gene therapy trial for any condition. This is now going back to 90s. But then the overall outcomes were not so effective because the total amount of liver that could be replaced by then was not sufficient. So we had to go back to the lab and begin to figure out more ways to replace the or to do the liver repopulation with cells. Now, this is a recently published study in Circulation where Dr. Karthi Resan, who some of you know, has been involved in setting up a company, and that company has then begun to approach CRISPR-Cas-based gene editing. And here are results from a non-human primate study in cynomolgus monkeys and mice as well. So this is quite interesting, well done, and I'll walk you through it. So the idea here is that PCSK9 is going to be downregulated. And we haven't really talked about how PCSK9 works in this setting. So what it does is it regulates LDL receptor, because without PCSK9, LDL receptor remains at the cell surface, and that allows it to deliver cholesterol to the endosomes, and then the cholesterol gets metabolized, LDL receptor gets recycled. But when there is lots of PCSK9, this process does not occur, and so that's the reason why cholesterol continues to be in circulation. So here, what they did was took 3 different groups, treated them with or without, and showed that there was editing that was significant overall. And that amount of editing then corresponded to, I mean, the editing was roughly about 70%, which is pretty impressive. And there was a corresponding correlation with decreases in the PCSK9 protein as well as decreases in LDL cholesterol. So that made sense. And again, they were able to, fit all those through correlation curves. There was not any evidence for any liver injury other than initial increases in AST/ALT levels that occurred despite the use of steroids and other things. So even though this was done with targeting of hepatocytes using synthetic oligonucleotide-based editing, there was some damage, but not metabolic changes subsequently. Now, there was persistent correction here. There is data for up to 1 year, which was quite impressive. Then they had done some safety analysis. There's a requirement by FDA to know that there is not going to be extrahepatic targeting or especially reproductive germline transmission, which had occurred with adenovirus vectors. So here they had shown that there was no such germline transmission either. So altogether in this study then, they were able to establish that PCSK9 can indeed be inactivated and that a therapeutic result can be achieved, and they've already moved on now to setting up a clinical study. You can look up the trial design there as well. So with those kinds of things, providing additional replacement of something that's missing, regulating alleles that may be disease-causing, and altering processes related to metabolic handling, it is possible to do gene therapy in specific, carefully driven cohorts to begin with, and then later on bigger samplings and bigger outcomes in bigger populations. That's where we stand at the moment. And I thank you for having me come and speak to you and to the organizers and everyone out here as well. Thank you.
Thank you, Dr. Sanjeev Gupta, for your insight about genetic modulation of cardiometabolic syndrome. Thank you.
Thank you. Memento time. So can I request Dr. Kushal Madan, Dheeraj Khurana, Soumitra Ray, Sanjeev has already received one, yep? Yep, okay. Thank you, Professor Ray, for a brilliant presentation. Also to the chairperson. May I request Dr. Rajiv Bhagavatta to do the work? No? Sunil. Sunil. Sohan Sharma. Sunil Sharma. Sorry, Sunil Sharma. Take on. Thank you. Thank you, sir. So for the next session, can I have the chairs, please? Shailesh Lodha, Dr. Shailesh Lodha, Dhananjay Agarwal, Sandeep Mathur, Dr. Didwania, if he is here, no. Monica Maheshwari, she is not here, Bhavesh Meel, Jugal Sharma, Manoj Sarwa, Praveen Sharma, Rahul Singhal, Sanjeev Sedana. So many are missing. Yep. So I request them to start proceedings, please. Yep.
Next session is on the future of the CAD prevention. That is important for all the disease, all the organs. For this, I invite Dr. Sandeep Mathur. He will speak on haptoglobin gene and cardiometabolic diseases. Dr. Sandeep.
Dr. Ram Prasad, please.
Good morning, everyone. And the next few minutes, I'll try to show how genomics can help in risk stratifying individuals, especially in the common myocardial infarction and coronary artery disease. So we have a pretty large disease burden in the country, and one single approach will not mitigate the burden. We have to use multimodal approaches, and I'll show how genomics can help at the clinic level, some of the studies that we have done and what we do at our lab, one of the South Asia's largest genomics lab, what we perform and what we work with clinicians across the country. So one of the dramatic things that has happened in the last 15 years is the paradigm shift in the time and the cost that it takes today to sequence the genomes. Starting 20 years back, when it cost $1 billion, and today sequencing costs much less than $1,000 today. And if you slice and dice and look at only specific genes today, it is possible for a common man in India who can test these things less than $100. Today, we routinely diagnose monogenic diseases which are primarily driven by genes, and we can understand, for example, in this scenario, a straightforward long QT syndrome, we can identify monogenic highly penetrant mutations and do cascade screening and manage the disease much better. Whereas in certain scenarios, like in this, where you're not sure about what exact diagnosis is it, but you know pretty well it's something related with cardiovascular disease, and you do for genetic testing, it can solve the diagnostic odyssey and identify the mutation which causes the disease. In this case is dilated cardiomyopathy. There are many situations where reverse phenotyping is done. For example, this case came to us with a primary diagnosis of cardiomyopathy and hypertrophic cardiomyopathy and suspect of Marfan syndrome. And when we sequence this, we identify a mutation in a gene called CBS, which primarily causes very high homocystinuria and which mimics exactly the same phenotype. So not just about specifying the diagnosis, but also in differential diagnosis where your phenotype is not very clear, you are unable to arrive at exact clinical diagnosis, we can identify, pinpoint exactly what mutation is it and what exact phenotype is it. While monogenic diseases have become mainstay in genetic testing, the biggest problem today is the common diseases like myocardial infarction or coronary artery disease or hypertension or diabetes. So how do we identify apart from the rare diseases? So there are two entities here, what we call monogenic diseases on the left side, where a single gene or a single mutation causes the disease. Environmental lifestyle impact is very minimal, extremely minimal, or even doesn't play any role. Whereas on the right side are the complex diseases where millions of genetic variants or several thousands of genes have modest effect and create a complete effect or complete influence on the phenotype. And it's an interplay with the environment and lifestyle and diet that distinguishes the outcome of the disease. So there are two aspects which I'll show you on the inherited basis of MI. If you look at on the left side, there's an individual whose name is Jim Fixx. He's a American fitness revolutionary who created a fitness revolution in US. And on the other side, you know pretty well, it's Winston Churchill. While this fitness revolutionary has died while he was running at the age of 52, whereas on the right side, this gentleman who was a chain smoker, who was obese, who had high cholesterol, survived till 90 years of life. So we see in everyday life many individuals like this who have high risk factors, including lifestyle, environment risk factors, but continue to live long with no coronary artery disease. So what is the risk that predisposes certain individuals who do not have any kind of clinical or even lifestyle risk factors? In fact, they have protective factors as far as clinical and lifestyle factors are concerned. And what is that protects individuals who have high clinical risk factors but still do not get the disease? While the protection part is a much larger part, examples being PCSK9 and few others, which I'm not going to talk today, but I'll talk more on how do you identify these risk factors. Why do some get disease at an early age? We saw one of the comment by the earlier speaker, when the LDL levels are not very high, when you don't identify individuals with clinical risk factors, how do you identify an individual who can be at risk or inherent genetic risk of getting coronary artery disease, probably young onset MI2? And genome to guide the pre-symptomatic risk assessment and also genome to identify pathways protective for the disease. So this is a distribution as for US averages, and India it might be slightly lower for the MI, and this is a normal distribution how it happens in the population. There are individuals who get MI less than age of 55. We call today them as young onset MI cases. And Some amount of reason are monogenic causes, which I will show you one example how it is. And majority of the causes are polygenic, and of course, lifestyle plays a significant role here, interplay with the genomics here. So if you look at monogenic model, these are some of the well-published studies, pretty well proven. And if you look at one of the studies done by Doe et al. In Nature 2015, pretty large longitudinal study, case control association study, where there are about 5,000 cases and 5,000 controls who are basically, cases are young onset MI cases, performed exome sequencing, which is basically sequencing the protein coding regions of the genome. And when you look at the variants which are strongly associated with those individuals who had young onset MI, among the 18,000 protein coding genes, there's one single variant which strikingly differentiates between both of them, pretty high odds ratio of about 8 to 9 and a significant high p-value. And this is nothing but the LDLR gene. Today it's well proven that LDLR gene, which increases the cholesterol levels, LDL-C cholesterol levels, is a very high risk factor. These mutations cause young onset myocardial infarction directly or indirectly. However, the problem is in this approach, roughly about 2 to 4% of individuals only have LDLR mutations. Individuals who have early MI have only 2% of them have LDLR mutations. So it doesn't create much impact as long as you use this, but still for individuals who have this kind of a phenotype, you can look at LDLR mutations. Now, what is the common genetic risk among common individuals? You see almost in your clinics every week, every month, you see individuals with no clinical risk factors, but still getting young onset myocardial infarction. So this is the way last 7 to 8 years it has been dissected. I'll show you some of the results of the Pan-India study that we have done. This is a case control association study again, and it has longitudinal follow-up also in the individuals. You can go to the website called Cardiogram Plus. You have complete details. It's a fantastic website which gives almost all the details of the longitudinal follow-up. And the number of cases are 60,000 across the ages. It's not restricted to young individuals who had an MI, but across the ages, 60,000 compared to the controls. Well-matched controls have been used, about 120,000. They have been genotyped, whole genome genotyping we call that as. Pretty low cost. Today it costs roughly about 3,000 to 4,000 rupees to genotype one individual at the whole genome level. And this is the Manhattan plot. As you can see, there are several of the genes and variants which are above the threshold, which have been associated with the disease with a modest effect. And they have identified roughly today about 7 million variants across the genome, which are at least mildly or moderately associated with common coronary artery disease or common MI among the populations. And how do you translate this into the clinic? So initially, Sheikh and others, this is a published paper in Lancet, they have published using 50 SNPs, which are very strongly associated with common coronary artery disease. And they have taken these 50 SNPs and created a simple score called polygenic risk score. This is not a genome-wide polygenic risk score. This is a very targeted 50 SNPs called polygenic risk score. And each person is assigned a score based on summation of these variants that they have among each individuals. And this is basically a polygenic risk score. All the variant alleles, risk alleles which are present, you create into a very robust statistical score, which is called as polygenic risk score. If you do variants across the genome, it's called genome-wide polygenic risk score. Otherwise, it's just called as a polygenic risk score. And now you see, after typing these individuals and generating the polygenic risk score for each individual, whether it's an individual who has a disease, who does not have a disease, you type this score, you can categorize these individuals into 3 groups. One is what you call high risk, one is an intermediate risk, and the other is an average or low risk group. Now to study whether actually the individuals with high risk group do have cardiovascular events in the long run more than or significantly higher than individuals who do not have high genetic risk score. This is the Malmo population study with a 14-year follow-up on the 2,213 coronary artery events which have happened in this longitudinal follow-up. So this is the summary of the study, which shows individuals who have high genetic risk score have significantly or 85% greater relative risk compared to individuals who do not have high genetic risk score. And today, with this, at least to great extent, this is not like a monogenic testing where you can pinpoint and say 100% sure this individual has a very high risk and is going to get an MI. But at least to great extent, with odds ratios about 3 to 4, you can identify, and hazard ratios about 1.74, 1.8. You can identify 20% of the population with a twofold increase risk of early MI based on common variant genetic score, and it impacts large population. You can identify high-risk individuals and stratify them pretty well, and put them into lifestyle interventions and even certain situations, pharmacotherapy also. And these are a couple of nice studies which have been published compared to atherosclerosis risk in risk communities in genetic risk versus lifestyle. You can look at individuals who have high genetic risk in the red line here, have a hazard ratio of 1.75. In the same way, individuals who have unfavorable lifestyle have an hazard ratio of 1.71. And how do you do it? While there are no formidable guidelines still available, how do you intervene these individuals? There are certain studies which have been published here. Now, if you look at across the population, individuals with a low genetic risk and a high genetic risk, if you control their lifestyle and put them in a proper healthy high lifestyles, individuals with a high genetic risk score benefit far better, significantly better compared to individuals with low genetic risk score. In the same way, this is a paper published on polygenic risk score, identifying subgroup with a high burden of atherosclerosis and putting them on statin therapy and primary prevention setting. And this is where it shows statin therapy benefits high genetic risk score individuals compared to average or low risk genetic individuals. And just on the final part of it, just to summarize some of the results that we have done across the country, roughly about 4,000 individuals. The study is still ongoing. We have recruited so far about 6,000 individuals of a genome-wide polygenic risk score. We created a population-specific risk score. We collaborated with Broad Institute with Amit Khera and Sheikh Kadresin's group. And the whole model has been established for Indian population. There have been some PCA corrections done based on Indian ancestry or South Asian ancestry. And cardiogram plus variants, 6.6 million markers were done. This is again the Manhattan plot, which shows similar genes and variants almost overlapping with the Caucasian study, which has been published in Cardiogram Plus. This is a replication of that study. And we created polygenic risk scores here. As you can see, individuals have been put in 10 buckets. We call decile approach from Q1 to Q10. And you can see Q10 is a high-risk group which has more number of individuals who are having young onset myocardial infarction already identified in this case. There's a paper published on, you can read it in the Journal of American College of Cardiology. And this is how we do it. Any individual who comes for this screening, we screen them and put them into the buckets with algorithm. And if some individual falls into Q9 or Q10, they are high risk. If they fall in Q8, they are moderate risk. From Q7 to Q1, they are intermediate risk. And the odds ratios can go from anywhere between 2.5 to 3.5 in this situation. So this is the curve we give it. And please note, these are common polygenic risk scores are not highly accurate. There will be still about 20 to 30% of individuals who have young onset MI but do not have high genetic risk scores. So you have to consider, but still 70 to 75% of individuals can be identified pretty accurately. And very interestingly, we compared these risk scores between the single vessel disease greater than 50 years of age, single vessel disease less than 50, which is a young onset MI. You can see the median polygenic risk scores are significantly higher compared to the single vessel disease with age greater than 50 years of age. And we do this. They in fact go in across the generations in a Mendelian fashion. This is a family who came to us with an individual with 31 years of age and MI event happening, and we did a cascade screening across the individuals and we could counsel them accordingly. The last one which to show, but this is a fantastic piece. Whoever is interested in common risk, genetic risk screening should read this paper. It's a multi-ancestry model with all the comorbidities like diabetes, hypertension, fitted as a covariates and increases the robustness of the statistical model. And this is how we replicated the same population, same scores. From 2.46 odds ratio, they moved to 3.16, increasing the accuracy of the population. So this is getting validated. Science is evolving very fast on this. More and more papers are coming. AHA has given a strong recommendation, cautiously optimistic, clearly mentioning PRS calculators apart from ASCVD or integrating with ASCVD. significantly improves prediction of cardiovascular events, and you can take mitigation measures accordingly. So you have your clinical risk factors combined with polygenic risk scores. You get the combined risk, which is a much more specific risk compared to using either of them alone. And that's how, and say there are inherited genetic risk factors. You identify them much ahead before they get the disease, and you can mitigate the risk and stratify the individuals in the population. Thank you.
Nice presentation by Dr. Ramprasad. For the next session, I invite Dr. Sandeep Mathur for haptoglobin genes and cardiometabolic diseases.
Thank you very much. At the outside, my thanks to Dr. Deepak and Rajiv sir for the opportunity to speak here. Haptoglobin is, we know, as a marker of hemolytic anemia, and this molecule will use in the hematofield of hematology and hemolytic anemia. But what I want to point out here is that this molecule the genetic variants in this gene possibly play an important role in cardiovascular disease in diabetics. Here it is not cardiovascular disease in general, but the cardiovascular disease in diabetics. So this is one of the so many coronary artery disease risk factor. But this has practical implication in terms of pharmacogenomics. And pharmacogenomics so important. This has opened the avenues of reappearance of a forgotten medicine for severe disease, that is your vitamin E. In fact, there is some emerging data that in future genotyping of your haptoglobin could be a guide for revisiting your vitamin E into your clinical practice for severe risk reduction in diabetic patients. Haptoglobin alpha glycoprotein, its major function of haptoglobin are to scavenge hemoglobin. Hemoglobin is constantly produced in our circulation. Very efficiently, it binds with it and actually prevent the injury to your blood vessels, including your renal vessels as well as blood vessels, because iron of hemoglobin, very strong oxidative substance. So oxidative substance is removed by this haptoglobin from your circulation. Actually, haptoglobin regulates angiogenesis, nitric oxide homeostasis, immune response, prostaglandin synthesis, and haptoglobin impairs iron load heme ability for pathogenic microns. So it prevents from infection also. So basically, whenever there is a hemolysis, haptoglobin binds with it, and it is taken up by a CD163 receptor, 163 receptors on your macrophages. So hemoglobin, which is constantly produced in your circulation, that is actually binded by haptoglobin, and this complex is taken up by the CD163 receptor on your macrophage, and this is how our cells are protected from oxidative stress caused by hemoglobin. And its levels are usually increased. Here I want to point out one thing. Haptoglobin level is something different than haptoglobin genetic polymorphs, because levels are increased whenever there is a stressful condition like glucocorticoid, catecholamine, bacterial endotoxin, inflammatory markers. The levels are decreased in your hemolytic anemia. But the other facet of the coin is that haptoglobin gene and its polymorphism. This gene is situated on chromosome 14, X6, 17, 7 exons. And there are few SNP markers. Actually, I just heard Ram Prasad, actually SNP markers and your jivas, we did jivas for diabetes almost 10, 12 years ago. That is not very important, because individual genes, its structure, its function, its regulation, everything matter in your pathophysiology. Simple presence of single SNP marker, because SNP markers are not very dense coverage. Now in the era of NGS, we are doing whole genome sequencing. Simple SNPs are not strong. The SNPs are not very important component of haptoglobin gene. But what more important related to haptoglobin is CNV polymorphism. Actually, let me clarify that. If there is a sequence variants, we call it could be SNP marker, it could be frame shift, it could be your deletion, alteration, duplication, all these things. But duplication of a gene between larger number of copies of a gene, we call as CNV polymorphism. So CNV polymorphism can be present within a gene. What I want to point out here related to haptoglobulin, it has 4 exons for alpha chains and 1 exon for beta chain. Exons are the regions of the genome in a gene that are reflected in your protein. It is reflected in mRNA, messenger RNA. And intervening region is intron, that is regulatory region or just nothing to do. So exons are duplicated in some of the individuals. So if, exon 3, 4 are duplicated, they are basically 3A, 4A, then we call it haptoglobin 2 polymorph. If it is not intragenic CNV defect is not there, it is not duplicated, then we call haptoglobin 1 polymorph. Apart from this, there are certain sequence variants in haptoglobin gene. They have some bearing with its molecule's function. And what happens? What more important, it is not the level of circulatory haptoglobin, but this is complex formation, because haptoglobin bind with the hemoglobin, but once it is haptoglobin 1 polymorph, it binds, it is very well taken up by your CD36 receptor on macrophage. If it is actually haptoglobin 2 polymorph, then it makes a polymer. And this polymer is not properly taken up by your macrophages because they can't pass through circulation to your macrophages. So here is the story. Apart from these defects, there are few more genetic variants like your Johnson variant, there are deletion variant, zero variant. But what more important, some of the regulatory regions of this haptoglobin also have polymorph, they affect its levels and its function also. So now coming to Indian scenario. This is very important. Globally, it has been reported prevalence of haptoglobin 2 polymorph, which is poor in reducing oxidative stress, that is pathological, harmful. Its levels are, its prevalence in Western countries is reported 35 to 50%. But in India, its prevalence reported to be as much as 88 to 84%. So this 2 CNV polymorph of haptoglobin gene is highly prevalent in India. In fact, some of the old electrophoresis studies published in 80s, they also showed its prevalence was very high in all different castes. Almost 79 to 80% of the people have haptoglobin 2 polymorph. The haptoglobin gene polymorph, diabetes and atherosclerosis, what is the molecular mechanism? As I mentioned, haptoglobin 2 polymorph or haptoglobin 2 polymorph, basically it makes polymer. And these polymers are not transferred from your circulatory compartment to your tissue compartments, and it's poorly taken up by our macrophages. So hemoglobin remains in circulation for a higher concentration. This higher concentration of hemoglobin lead to oxidative stress. There are different pathways, and increase oxidative stress, inflammation, vascular endothelial dysfunction. So 2 polymorph, higher concentration of your haptoglobin, and higher concentration of hemoglobin in circulation lead to tissue damage. And in fact, in diabetics, it is more so because diabetes not only have higher rate of hemolysis, but haptoglobin and hemoglobin complex taken up poorly by a poor expression of CD1C, the expression in macrophage in diabetics. And diabetics themselves also have an inflammation that affects your hemoglobin function and oxidative stress. So all combined increases it. Genetic polymorphism, this is the mechanism. Basically, more hemoglobin circulation, more your lipoprotein, that is HDL, LDL oxidization, as well as endothelial dysfunction, decreased nitric oxide, all contribute to your process of atherosclerosis and vascular damage. And this is basically a balance between basically oxidative stress as well as antioxidants. That makes sense. So it is the balance between oxidative your molecule and free radical scavenger that determines your damage to blood vessel by haptoglobin 2 polymorphs. So haptoglobin gene polymorphism and diabetic microvascular disease, because it damages blood vessels. As far as diabetic retinopathy, there were some isolated reports from Levy's group from Israel. The first report appeared. Then we have one report from India. They say that prevalence of haptoglobin 2, this is just simple, very simple epidemiological, very simple study, clinical study. The prevalence was a little higher. But recently a meta-analysis has been published, and that meta-analysis has clearly shown there is no association haptoglobin gene polymorphs or 2 polymorph as well as proliferative or non-proliferative diabetic retinopathy. It's not a factor. But as far as diabetic nephropathy is concerned, they were initially isolated reports, and they particularly look into haptoglobin polymorph in terms of albuminuria, microalbuminuria, macroalbuminuria, and progression of diabetic nephropathy. Evidences were actually promising and suggesting that haptoglobin 2 polymorph is associated with higher risk of albuminuria and progression of renal disease. In fact, even in type 1 diabetes, this study published in 2023 itself, that evaluation urinary haptoglobin level as a biomarker of diabetic nephropathy in children with type 1 diabetes, and they find Urinary haptoglobin level could be a biomarker for diabetic nephropathy, but it is not an early to albuminuria. But definitely it's a marker of progression diabetic nephropathy. But for type 2 diabetes, urinary haptoglobin creatinine ratio was found to be a very good predictor of decline in actually renal function. So if the haptoglobin 2,2 polymorph is there, and haptoglobin levels are also important, and if it is related to decline in renal function, in fact, haptoglobin to creatinine ratio might be useful predictor, predict patient with 2,2-DM at risk of nephropathy prior to development of microalbuminuria or reduction in GFR. So it can be a predictor of decline in kidney function in type 2 diabetic patient. Now coming to the other aspect of haptoglobin gene, polymorphs and CAD in diabetic, what are the evidences? Because already mentioned, if there is a haptoglobin 2,2 polymorph, there is higher oxidative stress, more damage to your oxidation of your lipoproteins, damage to your endothelium, and your atherosclerosis process. In fact, one study recently, there are several studies, they actually re-examined data of cardiovascular incidence, CV incidence data of landmark trial in context of haptoglobin polymorphs. That is haptoglobin CNV polymorph, that is haptoglobin 1, haptoglobin 1,1, haptoglobin 1,2 or 1,2,2 polymorph. And most of these studies, basically HOPE study, CHESS study, Munich study, iCare study, ADIC study, WHS and all, and they find definitely haptoglobin 2,2 polymorph was associated with higher incidence of cardiovascular diseases. So haptoglobin 2,2 polymorph in fact was found to be as much as 4-fold higher risk of cardiovascular disease. So 4-fold in some studies is basically eye-opener. Secondly, it is an important predictor of 30-day mortality in patient with myocardial infarction. That is again very important. All aspects of cardiovascular disease, not only prevalence of or incidence of cardiovascular event, rather than mortality in your diabetic patient. That is, can be predicted, worst prognosis can be predicted on the basis of haptoglobin 2,2 polymorph. Similarly, this small study find that restenosis was present in 33 out of 40 patients haptoglobin 2,1 or 2,2 polymorph, but none in 5 patients with haptoglobin 1. Those very small sample size from the Levy's group were published in NEJM as a correspondence. And they say that in this small size of patient, they find very important role of haptoglobin gene polymorph restenosis rate. Similarly, in the strong heart study, odd ratio of having CVD in DM with haptoglobin 2,2 phenotype was 5 times greater than diabetics with haptoglobin 1,1 phenotype. That means in diabetic, if haptoglobin 2,2 phenotype is present, CVD risk CVD is 5-fold higher. That is very alarming, though it's only one study's data. Now coming hyperglycemia, haptoglobin polymorph and vascular disease, because this is very important from diabetic. Non-diabetic population, there is not much good evidence haptoglobin make any sense. So in NHS study, haptoglobin 2,2 genotype, that is 39 frequency, was strongly related to CHD risk only among individuals with elevated HbA1c, that is 6.5, and association was similar to iCare trial and strong heart study. In a pooled analysis, participants with both haptoglobin 2,2 genotype and elevated HbA1c had a relative risk of 7.9 for CHD compared to participants with normal HbA1c and haptoglobin 1 allele. So this 7.9, this NHS data is very, very eye-opener. And in 2 independent cohorts, the risk of CHD associated with HbA1c 6.5 is pronounced in haptoglobin 2,2 genotype, particularly in early cases. So haptoglobin gene, when it conspires with hyperglycemia, that is basically a risk factor for enhanced cardiovascular event and cardiovascular disease. In fact, in ACCORD study re-examined, because we failed as an endocrinologist to prove value of tight glycemic control in reducing cardiovascular event. Rather, those studies which are landmark trial, which everyone knows, there was an increased incidence, But reanalysis of ACCORD study data in context of haptoglobulin genotype, intensive glucose lowering therapy was effective at preventing incident coronary heart disease and CV events in ACCORD study participants with haptoglobin 2 phenotype but not H haptoglobin 1 carriers who had increased mortality risk from intensive therapy. You know, now we can be more personalized because in complex state, because I am a complex state endocrinology, I might work on adipose tissue and transcriptome, all those things. I thought coronary disease very complex subject, and this is a single molecule haptoglobulin, a single gene monogenic issue, and it has so much importance bearing on our day-to-day diabetes management, because we can go for intensive control in a group of patients who have haptoglobin 2 genotype, and it could be the reason for failure of some of the landmark trials to prove the value of your intensive glycemic control. So this is very interesting. Now coming role in refractory hypertension, there are two studies I see in literature. Hypertensive patient haptoglobin 2 phenotype are at just 1 minute only, have higher risk of developing refractory hypertension. Similarly, they had more atherosclerotic hypertension. Now coming therapeutic implications. Because vitamin E is a very effective free radical scavenger, and oxidative stress can be drastically vitamin E. But you know, meta-analysis published 2005, vitamin N role in cardiovascular risk reduction. But re-examination of the landmark trial, that is your HOPE study, WHS study, and iCare study, revealed that vitamin E supplementation in haptoglobulin 2 polymorph, particularly diabetics, it has significant impact in reducing the cardiovascular outcome, MI risk, as well as mortality risk. So T2DM patient, haptoglobulin 2 polymorph, and vitamin E has a successful study. So my conclusion is that haptoglobin is an important hemoglobin scavenger, thus controls oxidative stress and consequent vascular renal damage. Haptoglobin 2 polymorph associated not only heightened oxidative stress but also increased risk of both micro and macrovascular disease of diabetes. The risk is further increased in presence of hyperglycemia. Now the emerging evidences suggest reducing oxidative stress in T2DM, not diabetes mellitus, not type 1 and type 2, both in fact. Haptoglobin 2 or 2 genetic polymorph with vitamin A could be a scientific and pharmacogenomic based strategy for reduction of incidence of CVD disease in diabetes. Thank you very much. And why I have come to cardiologist here, because we are planning a long-term strategy, and in fact we have got good funding from industry, and I am in touch with Professor Levy. So I'm very much interested in views and support from cardiology to provide me patient, because we will be able to genotyping and other things in my lab. Thank you very much for your patience hearing.
Thanks, Dr. Sandeep, for nice presentation. I have one comment that in diabetes, genetics play a very important role, particularly in the development of diabetic nephropathy and progression of nephropathy to the end stage renal disease. So haptoglobin may be one of the genes, and ultimately many of the other factors are important for development of the nephropathy and from nephropathy to progression of renal disease. So we should identify those families where the progression is very fast for development of CKD, and we can prevent development of CKD and dialysis dependency. Thanks for all. Okay, thanks for Sandeep.
So it's my pleasure to invite my esteemed teacher and a great geriatrician in Rajasthan, Dr. Arvind Mathur, for his talk on enhancing longevity and health span.
At the outset, I thank Professor Dr. Rajiv Gupta and his team to have given this opportunity to be with all the distinguished cardiologists. I'm an internist practicing primarily for the old age persons. And when they asked me to talk about this particular subject, can we enhance longevity and health span? Then I realized that each one of us want it. And probably for all these years, we have been thinking of it and have been praying that God should give us something so that we have an increased longevity. With the public health development and even the preventive measures which we have been taking, particularly for the cardiovascular diseases, they have impacted the lifespan. And the life expectancy of our country has doubled from 1950 to present time. So this has been a great public health achievement which we have seen. Now, we all know that these measures have been due to the commonly known factors which we have been using for the cardiac prevention. Because we are going to talk about the future of CAD prevention, but I want to emphasize that these measures are very important and they have already yielded very good result for us with diet, regular exercise, stress management, adequate sleep, smoking and alcohol limitation, regular monitoring, social connectedness, that is also very important. And along with this, certain genetic issues, calorie restrictions about which we'll be talking about some subsequently also, fasting, and certain anti-aging therapies or so. So these factors have already worked in past so many years. We all realized that the poor lifestyle habits have been responsible for most of our miseries. And for this particular segment of medicine has come up as a lifestyle medicine, and which advocates that we try to use these measures for prevention. And one thing which has been recommended, that the assessment of lifestyle factors should be part of a vital sign recorded during the patient visit. And remember, the visit of the patient to the doctor is the best opportunity, a window of opportunity for imparting them education about prevention. So lifestyle medicine should be integrated into the core competencies of all specialties, I would say, because this particular part has been responsible for all the ailments which we suffer these days. Now, what we saw that with the life expectancy increasing, the lifespan has increased. We have got a lot of older people in our community, but this has come with a cost that with the age, the chronic degenerative diseases, they have increased. Earlier, the infectious diseases were common, but now we have dual burden of both chronic degenerative non-communicable diseases and the infectious diseases. And in this, aging is the major responsible factor, risk factor. Earlier, it was not considered that AIDS is a disease. AIDS is not disease, but it's an important risk factor which is responsible for many of them, and they have been mentioned as the comorbidities of aging. Now, with the increase in the lifespan, the healthy lifespan has not increased. We have older people who stay sick for a longer period, and there comes the issue of health span. In 1980, Fries promoted a term, compression of morbidity, wherein we wanted to defer the onset of these chronic diseases towards the end of their life, so as to reduce the burden of the disease. Thereafter, it was felt in 2009, the term of health span came, where we wanted a period of life free of major diseases in most of the time when we live. And when it comes to longevity, we wanted optimal longevity, where the goal is that we live long but well. So when you look at this diagram, we see that we extended the life, but the duration of sickness also extended. So we are looking for a compression of morbidity and increase the health span. Now, it has been found that the health span depends upon the physiological changes which occur with the aging. With the aging, we have seen that vascular dysfunction is there, which is responsible for many of the ailments. It is responsible to contribute for, besides cardiovascular diseases, to dementia. It has been responsible for other ailments also. The other aging-related changes which we notice are like peripheral insulin resistance, reduction in GFR, the impaired diastolic filling, immune dysfunction or immunosenescence, or the neuronal dysfunctions. All these things, they lead to functional deficit. Nowadays, in old age medicine, we are talking of intrinsic capacity and functional ability. The idea is that we do not talk of a particular disease. We are just trying to look at what are the capacities of that individual and how much functional is he. So these changes, physiological changes, they cause dependence, they cause functional dependence, and they should be the target for our action. So now with this, we have realized that aging is an important risk factor. And we have realized that there are several diseases which are associated with the aging. Instead of working for a prevention of each one of them, say like we have got Parkinson's, CVA, or hypertension, stroke, Alzheimer's, etc. If we start working for prevention of each one of them and then try to work on that, instead of that, if we could work to slow the aging, that will prevent most of the ailments. So delaying the age-related disorders is important, and we have to work to slow the process of aging, for which there are several ways in which our scientists, researchers are working, and it's a real phenomenal thing which they have been doing it. So now, with this, our aim as any healthcare institution has been to seek fundamental knowledge about the nature and behavior of living systems and application of that knowledge to enhance health, lengthen life, and reduce illness and disability. So that is what we are trying to look for about the increasing the longevity and health span. For this particular thing, a biological field has come up as a geroscience, which is trying to work on aging. Earlier it was thought that age is not modifiable. But with geroscience, we are already working on this, that we can modify the biological age so as to alleviate the age-related diseases, dysfunction, and longevity. So now it aims to prevent the development of those disorders. So the prevention is going to be there at that particular part. And for this, we need an understanding of the biological mechanisms of aging. And we have to identify novel agents for targeting those pathways. And for this particular part, what is happening, that the scientists have been working in the lab to identify the mechanism. They know the pathways where it can work. But when it comes to developing a drug or an intervention for humans, clinical trial, it becomes quite difficult. It's very difficult to have a clinical trial for longevity or health span. Most of the studies have been done on nematodes, or the fruit fly has been the one model for this. So they have been done in the animal models. But when you want to translate it and translate it for a clinical use, then there have been some barriers, for which now the proof of concept studies or early stage trials are underway. So when we talk of geroscience, we have to look at the 7 important pillars of aging. The age-related changes, mechanism of aging, they involve macromolecular damage, epigenetics, inflammation, adaptation to stress, proteostasis, stem cell and regeneration and metabolism. So all these have been mentioned as the 7 pillars of aging, and the scientists have been working at various levels to intervene at these particular places. It's like adaptation of stress. There are certain studies going on: epigenetics, inflammation, macromolecular damage, metabolism, proteostasis is an important area, stem cell and regeneration. So these are the areas where they have been working. And for this, the compounds which are being used and are being prepared, they are called geroprotectors. These are the geroprotectors which would protect us from the aging. So there are hundreds of them. So when you look at the publications related with the anti-aging mechanism, you find there has been a sudden spurt in the number of publications. And since the geroscience started in 2005, but in last 3-4 years, there have been number of publications in this field, and there have been various studies about it. The pharmacological interventions, they have been working on these areas like prevention of oxidation, proteostasis, etc. So since there are several mechanisms of aging, because aging is not one single mechanism, so the interventions are also multiple. We have seen that certain diets, as was mentioned today by Dr. Ansari also during his talk, that there are certain blue zones where the diet has been responsible for longevity. So these diets have been shown to have reduction in the chronic diseases, and calorie restriction has come up as another way for prolonging the longevity. And there are several types of diets which have been promoted for calorie restriction. Along with this, there are certain pharmaceutical interventions are also being prepared which will mimic the calorie restriction. So besides this, today morning we heard about metformin, which is also being tried, but there are certain concerns about the use of metformin also. But okay, those trials are underway. They will give us the answer. Besides metformin, there are several other agents, drugs, which have been repurposed for the purpose of anti-aging, like simple minocycline, doxycycline, dapagliflozin, there are several of them. The number has been increasing every day. And there are nutraceuticals. These are the compounds which are found in the normal food items. Particularly, you must have heard about the red wine, which is useful. It's because of resveratrol, which is one agent which has effect on the anti-aging, on the aging mechanisms as such. Similarly, omega-3 fatty acids, and there are other NAD plus boosting agents, several others, including where curcumin is being tried for this particular purpose. Herbal medicines have claims for anti-aging effect. There have been a systematic review recently published in 2023 itself only, which showed that they have been effective in certain ways to affect the aging effects. But again, they have mentioned that they need to be studied further for their appropriate prescription. One more thing which has been shown to have impact on the aging is gut microbiome. And it has been seen that it does change the immune functions of the individual and disease susceptibility. So that is another area where the interventions are being looked into. We found that the social, demographic, and psychological factors have an intense function on the aging of an individual. It has been shown in one of the studies that the 80% of anti-aging effect is because of your emotions, your happiness, and rest is others. So these mechanisms, they also have their way of affecting the aging mechanism through their work on the... So, dear friends, I'd just like to conclude. It has been our goal to have healthy longevity, and with the establishment and improvement of public health system, our life expectancy has increased. but it also faces the challenge of increasing number of aging-related diseases. Our aging can be delayed with genetic, dietary, and pharmacological approaches. Geroscience research on aging-related disease has also become a major focus of scientific research and public health system. And there are new methods, new research drugs, new treatments are emerging. And establishing and using new methodologies such as genomics, proteomics, metabolomics, single-cell transcription, and artificial intelligence applications can directly target aging and aging-related diseases to study mechanisms and explore prevention and treatment methods. However, the emphasis on lifestyle modifications, including diet, physical activity, smoking cessation, stress, and weight management, has to continue. Thank you very much.
Thank you very much, sir. Thank you very much for your nice talk. Please have a seat. I now invite Dr. Ruchi Gupta for a very interesting talk, New Risk Factors for CAD.
Good morning, everyone. First of all, I'd like to thank the organizing team and the entire faculty and delegates to have given me this opportunity to be coming here and presenting this interesting topic in front of you all. So I'll begin. Now, what are the new or unforeseen risk factors? These are the risk factors which have not been contemplated so far. That means we don't have some guidelines to which we can follow to measure them and to follow a certain parameter to kind of give treatment for them. So when we look at the CAD patients, of them, 30 to 50% of patients have been reported without having any conventional risk factor. More than 100 new emerging risk factors have been discovered for their ability to improve the global risk assessment. But when we are diagnosing or finding new emerging risk factors, we need to be addressing these three questions. Is the biomarker readily measured? Does the biomarker add value to the existing tests and improve its risk predictive ability? And will the biomarker enhance clinicians' decision-making ability and improve the patient management? So if the emerging markers are able to satisfy these questions, only then they become part of our management strategy. I'm not talking about the conventional risk factors like the non-modifiable, modifiable, age, race, and smoking, etc., because they've been covered a lot. I'm talking about the new factors, of which the commonly discussed are hyperhomocystinemia. Normal values are less than 15 micromoles per liter. Thank you. So the normal values are less than 15 micromoles per liter. So anything more than that increases the risk of CAD. The role has especially been seen in young CADs. Then lipoprotein A, the normal values are less than 30 milligram per deciliter. Anything more than that has been found to be associated with early CAD. And we've already had 2 lectures on lipoprotein A and have discussed them at large. Hypertriglyceridemia, values less than 150 milligram per deciliter are normal. Anything more than that has been found to be associated with increased risk of CAD. Now the new ones which I'm talking about are apolipoprotein B/A ratio. The normal is 0.5. More than that exponentially increases the risk of CAD. And presence of small dense LDL particles as acclaimed in Journal of American Heart Journal of America 2021. Now when we look in the detail, we see that the small dense LDL particles increase in presence of higher proportion of apolipoprotein B. So that means the ratio, increasing ratio of apolipoprotein B/A indirectly correlates with increase in triglycerides and increase in the small dense LDL. So they are all related. Now, talking about apolipoprotein B. So, as the proportion of apolipoprotein B is increasing, you can see in this diagram, the small dense LDL particles are increasing, and as the ApoA levels are increasing, the proportion of HDL lipoproteins are increasing. So that's why the ratio between apolipoprotein B/A, as it increases the risk of CAD. This is an Amoris trial which discussed about the fatal myocardial infarction. It was a comparison between the odds ratio and ApoB/ApoA, and we find that the ratio more than 0.5, and when it reached to 1, there was an extensive increase in the number of myocardial infarction when the population was adjusted for age, gender, total cholesterol, and triglycerides. Now, I'm talking about the risk factors which can be assessed by imaging techniques. I think we do have a session on this in details. So, on imaging, we can see the carotid intima media thickness and the coronary artery calcium score. So, talking about the carotid artery intima media thickness, it is 0.9 millimeters or less taken as normal, but anything more than that increases the chances of CAD. There is a comparison in the pictures where in the C, you can see in this slide, you can see in C, there is an increase in intima media thickness, and corroborative in the coronary angiography, we can see a diffuse disease in LAD. Now, how do we measure it? It is done by a linear probe scanning. So, it is done by a linear probe scanning of carotid artery, and when there is a decrease in the lumen because of increase in the IMT, it leads to a plaque formation and later on can lead to a plaque rupture. Now we talk about the coronary artery calcium score. It is the score given by Cleveland Clinical Calcium Scoring System and is done by EBCT, that is electron beam CT scan, and a score of more than 500 has been shown to be extensively associated with coronary artery disease of more than 50%. And anything more than that has been found to be associated with significant stenosis. Now I'm talking about the risk factors, assessment by clinical examination and bedside tests. So these are the common ones. They are ankle brachial index, periodontic and endodontic diseases, and heart rate. Taking one by one, when we talk about any infection, and especially we're talking about periodontic lesions, they lead to bacteremia. Dyslipidemia is already there because of inflammatory mediators are released, and it leads to atherothrombotic lesions. So, but what has been seen is that definitely there is an association between periodontic lesions and CAD, but what has been found is that in more than 40% of these patients who were assessed, the common risk factors like smoking, hypertension, and diabetes coexisted. So we actually don't know whether there is a causal relationship or whether there is an association found because of the conventional risk factors present in both of them. Now talking about the ankle brachial index, an index less than 0.8 signifies moderate arterial disease in the peripheral arteries, and peripheral arterial disease has already been classified as a high risk sine qua non to coronary artery disease. So it is the ratio of systolic pressures at the ankle to that in arm. It can be very easily measured bedside and can be taken care of and treated early. Now talking about heart rate. So how does heart rate affect coronary artery disease? Now elevated heart rate has been known to cause atherosclerosis by increasing the endothelial dysfunction, increasing the oxidative stress, decreasing the plaque stability, and increasing the arterial stiffness. All this leads to ischemia, decrease in oxygen availability, and causing the increase in atherothrombosis. Also, it leads to remodeling of the heart and increased incidence of heart failure. After talking about the imagings and the bedside risk factors which can be easily taken care of, we're talking about the risk factors assessed by blood assays like ELISA, etc. They are leukocyte count, high sensitivity CRP, a value of more than 0.8 milligram per liter is taken as abnormal. We're talking about myeloperoxidase. High risk are a value of more than 540. We talk about fibrinogen, more than 400. Vitamin D deficiency, F2 isoprostanes, and lipoprotein phospholipase A2. So many of these are pro-thrombotic, pro-inflammatory agents. Now taking them one by one, when we talk about leukocytosis, it actually affects all the organs and it can be present in any of these diseases as well. So definitely it is associated with cardiovascular disease, but a causal relationship has not been found so far. In leukocytosis, monocytes are found to be associated with increased aggregation in the intima of the coronary arteries and causing atheroma formation. So there have been 14 studies in which TLC count did not predict the major CAD events consistently. So the analysis was not limited to only intermediate risk patients, and that's why it was not quality adjusted with the Framingham risk factors and could not be evaluated properly. Now when we talk about HSCRP, we all know that it supports the monocyte recruitment, induces the production of tissue factor, ultimately mediates LDL uptake by the macrophages and increases the atherosclerosis and is localized in the atherosclerosis as well. So now I'm coming to myeloperoxidase. Myeloperoxidase also leads to myocardial injury, protease activation, and adverse remodeling and heart failure, but it actually can also lead to plaque initiation and progression, and it acts like a catalytic sink. When we talk about myeloperoxidase are present within the atherosclerotic plaque in human arteries and contributes to atherogenesis by catalyzing oxidative reactions in the vascular wall. MPO strongly predicts future CAD events in healthy individuals independent of other traditional risk factors, indicating that MPO is a potential clinical useful marker for CHD. Now when we talk about fibrinogen, a level of more than 400 has been found to be associated with an all-cause increased mortality. Talking about vitamin D. So vitamin D deficiency has been found to activate the renin-angiotensin mechanism as per the Framingham study. So deficiency of vitamin C also leads to increased incidence of diabetes mellitus, hypertension, and hypertriglyceridemia as mentioned in a cohort study published in 2011. So vitamin D deficiency does increase oxidative stress, immune dysfunction, hyperparathyroidism, hypocalcemia. It leads to inflammation, thrombosis, and VSM proliferation. All this leads to vascular dysfunction and atherogenesis. Now, interleukin-6 soluble ICAMs, type 2 secretory phospholipase A2, LDL and PLAPs, they've been found to be in high proportion in chlamydia pneumoniae and CMV infections. And all of these pro-inflammatory agents have been associated with a higher prevalence of CAD, but whether they play a causative role is not clear so far. A 4 years multiple cohort study has been able to show a very weak relationship of fasting blood sugar levels and CAD. So diabetes, we already know that has a strong relation. It is taken as a high risk factor, but only the elevated fasting blood glucose level does not. There is a passing reference to a previous radiation exposure to the chest. Multiple small population-based cohort studies have demonstrated that long-term cancer survivors who've had previous exposures to the chest, especially the mediastinum and left shaft area, appear to be at increased risk of developing heart disease. Now this is just to show that there is an essentiality of integrating the diagnostics, the therapeutics, the metabolics, and the gene therapy for the newer risk factors to be properly taken into the spectrum. Now, though the management is not the part of this, what I mean to say is that we study mostly the intermediate risk patients, and the patients who are found to have any of these emerging risk factors we are capable of analyzing them. And if we find them positive to the levels that we stated, we should intensify the preventive treatment, the statin therapy, because that is going to prevent them to enter into the high risk. So, and hormonal replacement therapy has also been talked about in the postmenopausal women, though it increases the risk of CA breast, but it is being talked high these days that it should be included in the postmenopausal state to decrease the risk of CAD in women. Dental hygiene can always be taught, lifestyle management can always be improved, DHA supplements can be added. There is one drug, adiponectin, which has been talked about. It is an anti-inflammatory and has been found to have good effects. We can always talk to our patients starting the Atkins diet, which is a low glycemic index diet, and we can add vitamin D supplements if required. So these are the things which are not going to do any harm. And if we have a patient in the intermediate Framingham risk score with any of the new emerging risk factors assayed, then these small initiatives can be made to prevent them to be entering into the higher risk. So to conclude, genetic risk factors be tried and treated with genetic correction and editing. Intermediate risk carriers should be evaluated with the possible emerging risk factors. Reclassified and preventive therapy be intensified. Coronary artery calcium score, CIMT, lipoprotein A, hypertriglyceridemia, hyperhomocysteemia have been found to be directly associated with increased coronary artery disease. Increased pro-inflammatory markers like ICAM, fibrinogen, PLAP2, interleukin-6 are found increased in cases of CAD. Evaluation can help in prognostication and intensification of the treatment. Ongoing researches and studies can make us wiser for coming times. Thank you so much.
Dr. Ruchi, for good presentation. I have one comment. During renal transplantation workup, we found that many of our patients, they have positive for CMV infection. And CMV, most of them have IgG positive. So we consider when they have a positivity, that may be additional risk factor for including the coronary risk factor and deactivation of disease. So CMV may be the occult infection, benign things are there, but they may be the added value for the coronary risk factor.
Thank you.
So thank you, Dr. Ruchi. And for the next talk, I will like to invite Dr. Rajneesh Joshi. Dr. Rajneesh Joshi is here? Yeah. So Dr. Joshi will speak on cardiovascular benefits of milk and dairy products. I think very relevant topic. So over to Dr. Rajneesh.
Very good afternoon to all, and I would really like to thank organizers for this topic. This is not about a drug, this is not about a gene, this is not about a molecule, it's about milk. It is, and I was looking at all the slides since today morning, somehow nobody has spoken about milk and dairy, so I think this brings this particular topic a lot of novelty. So very quickly, milk and dairy products, as far as research is concerned, are divided into two broad categories, low fat and high fat. So low fat milk can produce low fat curd, yogurt, buttermilk, cheese, and high fat milk can produce high fat curd, yogurt, buttermilk, cheese, but also cream, butter, and ghee. So to simplify things, as we process milk and ferment it to curd and cheese, the calcium content increases, the phosphate content increases, lactates increase, total nitrogen, which is a reflection of protein, increases, as well as there is an increase in fat content. But this is kind of an oversimplification of the entire story. And actually, the milk products are a huge spectrum. So very quickly, the blue areas are the raw milk, which have about 3 to 5% of protein, and its variations which would have a higher fat content. The topmost darker blue and white is how it is converted to cream and butter, which have a higher fat content. And on the left side, we have orange and red, which are fermented products, essentially yogurt and cheese. What we consume mostly in India are yogurts, which would have around 10% of fat content, and softer cheese, which would have about 33% of fat content. In Europe and in North America, there are hard cheeses, which have a higher fat content, say up to 66%. Peculiar interest is buttermilk, which we consume fairly commonly in India. It has a very low fat content, about less than 1% of total. So traditionally, milk and dairy products are associated with saturated fat, and overall, many guidances have been there which have said not to use it. So we have two themes which are happening in health sciences. One is animal fat is bad for heart. Dairy products have a high proportion of saturated fats, and minimizing dairy products and dairy fat prevents cardiovascular disease. This is one narrative which is popular. And then there is another narrative which starts from pediatrics, maternal child health, that milk is best nutrient for a growing child, and it has benefits. It has beneficial amino acids, phospholipids, medium chain triglycerides, calcium, vitamin K, probiotics. And probably somewhere during adolescence, as we shift from adolescent to adult, this green narrative goes away and we shift to an orange narrative that milk and milk products are probably not so good. I looked at dietary guidance to improve cardiovascular health, AHA 2021, and it has a constant feature for many years now, which is feature 4, and it says low fat or fat-free dairy products instead of full-fat dairy products should be preferred. There are a number of justifications which come for this guidance from previous research. However, this 2021 document says at the very end of this that this approach is currently debated, and there is some benefit that fermented dairy is actually beneficial, and I'll come to this. So far, there has been conflicting evidence. Many speakers have spoken about DASH diet. DASH was a diet rich in fruits, vegetables. Low-fat dairy was one of the components, and low sodium was another component, which in randomized controlled trials published in NEJM in 1997 and 2001 proved that it is useful in reducing blood pressures. And this whole package was taken in various guidelines because RCTs give us a very good evidence. But again, let's take it with a pinch of salt that this evidence was for a collective DASH diet rather than a particular component of this diet. Thereafter, more recently, there have been some studies which say that risk factors, cardiovascular risk factors, are either consumption of dairy and dairy products are either neutral towards cardiovascular outcomes. Some have said that no, they are actually harmful. And then we have variety of studies which are largely published in nutrition literature rather than in cardiovascular literature, which conflicts various evidences which are there. One study which is often cited in support of replacing dairy fat with vegetable fat comes from pooled data from 3 cohorts in United States, which studied about 1.3 million individuals with 14,000 odd CVD cases. A prominent finding was that dairy fat does not reduce cardiovascular risk, but there was modeling which was done in the same cohort which said that if this dairy fat is replaced by vegetable oils, the risk would even be reduced. Now this data is challenged by more recent studies. So this was a meta-analysis till 2017 where use of dairy fat as far as cardiovascular risk was either neutral because most lines are crossing 1, but surprisingly none of the line moved towards an harm. So harm was never proven, but benefit was never proven either. So now I'll come to a study where India was also a part. Pure study, India had variety of centers. There were 21 countries, 1.3 lakh individuals were collectively formed a global cohort. This cohort was established in 2003. We had results about dairy part from this cohort reported in Lancet in 2018. Basically, in 2003, a food frequency questionnaire was used, and people were asked what do they eat in terms of various foods. And the analysis part defined 1 serving of milk as 1 glass, 1 cup of yogurt as 1 serving, and 1 TSP of butter as 1 serving, and converted these food intake into servings. Very interestingly, this is the only study where global comparisons on how much milk and how much milk products do people across the world consume. Most studies previous to that were either Western studies or there were limited Indian studies about this data. Now in a single study, the blue line is a line to, blue bar is a bar to follow. This is South Asians, which includes us. We consume a lot of whole fat dairy and much less of a low fat dairy as compared to the Europeans. We consume a lot of milk and curd as compared to Europeans who consume more of milk, a bit of curd and somewhat of cheese. In Indian or South Asian cohorts consumed much less of cheese and butter in this particular cohort. So interestingly, the 2018 analysis, that is 15-year follow-up of pure cohort, revealed that in fact individuals who are consuming more dairy products, that is 2 or more servings per day, had significantly lower composite cardiovascular and death events, had significantly lower mortality, and had significantly less major cardiovascular disease. And all these odds adjusted for other cardiovascular risk factors were actually protective. So this large 2019 study published in Lancet reported that individuals who consume 2 or more servings of dairy per day are actually protected against mortality and protected against cardiovascular events. Yet milk and dairy doesn't figure in standard cardiovascular protection guidelines for a variety of reasons. If we analyze these results more clearly, there was more of a surprise in store, and the surprise was that whole fat dairy, that is, dairy which is made up of entire milk without churning out or removing the fat content from it, which is largely consumed in South Asia, had a clear protective effect and clear dose response effect. As for a composite outcomes, individuals who were consuming less of dairy as compared to who were consuming 2 or more servings per day had a clear benefit in terms of composite outcomes, clear benefit in terms of mortality, and clear benefit in terms of cardiovascular disease also. This was also surprising because so far the paradigm has been that whole fat is bad and low fat is good in terms of dairy products, and this multinational study kind of reported quite the opposite. More surprise was that when all kinds of dairy products, low as well as high fat, were combined together, the protective benefit melted away. In the sense that we don't have a clear dose-response relationship when in this curve, this forest plot, as we had in the previous one, which looked at only whole fat dairy. And it's a perplexing and goes against logic that apparently low fat is not as protective as high fat is, and this is surprising, and this is a matter of debate currently. Interestingly, benefits were related to region. Countries which had high dairy intake, such as Europe, North America, South America, and Middle East, the benefits were not so clear. In fact, it is the forest plot, the 95% confidence intervals, they cross 1. However, in low dairy regions, those who consumed more dairy products, there was a better benefit. And this brought a concept which is there for last 2 or 3 years, that up to 200 grams of dairy per day is in fact beneficial. And if you have more than 200 grams dairy per day, the benefits are uncertain. A clear indicator in all these curves is that nowhere consuming dairy is a risk, whether it is a high fat or it is a low fat, or it is in a high dairy consuming country or in a low dairy consuming country. So Pure Study 2018 concludes that consumption of dairy products might be beneficial for mortality and cardiovascular disease. Potential benefits are particularly useful for protection of stroke. The benefits were not statistically significant for acute coronary syndrome and heart failure. Benefit of curd consumption was consistent with previous European studies which had reported that fermented products are better. And the study concludes that consumption of dairy products should not be discouraged and perhaps should even be encouraged in low middle income countries where dairy consumption is actually low. So it brings to a concept of that there should be, or there is probably some kind of an optimal dairy consumption limit, which various nutritional studies and nutritional guidelines have pegged up at 200 grams or 2 servings per day. There are a number of butter studies. The red ones report that it is harmful. There is one green one, which is a systematic review of 9 cohorts, which says it has a neutral effect on CVD mortality. Ghee is a product which is peculiar to South Asia. There are a number of ghee studies from India as well as from Pakistan. There are a number of red ones which say that it is harmful. There are a number of green ones which say that it is not so harmful, either it's a neutral effect. There is one study which said that it is better, although it is a long back published study. So while butter and ghee would have a greater controversy, there is a more clearer evidence in favor of either cardiovascular event neutrality or even cardiovascular benefits as far as fermented milk products, which is curd and cheese, and whole milk is concerned. So if we look at various cardiovascular risk factors we bother about today, there are 2 ones in the green where studies, and this comes from some systematic reviews, that there is a favorable effect, especially for fermented products, in LDL cholesterol lowering and reduction in subclinical inflammation. And for all others, that is weight reduction, waist circumference reduction, HbA1c reduction, insulin resistance, HDL-C rise, or triglyceride lowering, it is neutral. Means dairy doesn't cause an adverse effect on these factors. It doesn't improve these factors, and it is neutral. So you really won't gain weight if you have fermented or non-fermented dairy products. Now, mechanisms of potential benefit are debated. One is that it would reduce appetite, and it has a weight neutral effect and reduces fatty acid reabsorption. Second is that milk-based calcium content has a favorable cardiomyocyte excitation contraction coupling. And third, which is most popular these days, is gut microbiome interactions, especially from fermented dairy, fermented milk or fermented products, improve intestinal integrity, reduced endotoxemia, and improve insulin sensitivity. Now, this is all in realm of physiology and nutrition science, but again, there are number of mechanisms which are being proposed for milk and dairy products being beneficial. This is what happens when we have a particular message given time and again in the community, and this is a message how health messages impact industry. Well, this data and this curve is from US, which says that thick black line in between shows dairy, that after 1930s there was a decline in dairy product consumption and more of vegetable fats and oils, and this gap increased more and more after 1970s. Again, we have a very different evidence coming especially from low and middle income countries and also from Europe, that dairy may not be as bad as it was pegged out to be. This is again from United States, where over a period of time, the whole fat dairy consumption declined and less fat and skimmed dairy consumption increased. 2018 and other studies from multi-country studies as well as studies from US and Europe now indicate that low fat may not have any particular health benefit and whole fat may be good enough. So it brings us to bottom line, and it brings us to our industry. So we have a number of cooperative brands of dairy in each state of India. So this is kind of national integration that way. Bottom line today, which is reflected in many studies and articles currently, is that milk and dairy consumption has a favorable effect on cardiovascular risk, especially in populations with a low dairy intake. So populations such as in South Asia, populations such as in Southeast Asia and Far East, which traditionally are low dairy consuming, there are benefits which are proven in cohort studies. Intake of dairy products up to 200 gram per day needs to be encouraged. Now this 200 gram is kind of an empiric limit, but this 200 gram comes from 2 servings. So about 2 servings of milk per day or 2 servings of yogurt per day would bring to this limit. Fermented products are better than non-fermented products. And lastly and more importantly is consumption of low-fat dairy as compared to high-fat does not have any added advantage. Whole issue is total grams of the product which is consumed. So probably milk and dairy will find its place in cardiovascular preventive guidelines, hopefully in few years to come. Thank you very much.
Dr. Joshi, I want to ask about what is the value of cow milk, goat milk, and camel milk. How we rate them in terms of the cardiovascular risk factor?
Okay, so Sir, as far as milk which is coming from different species, in studies they did not distinguish that, largely because cow milk or buffalo milk is a predominant milk consumed in South Asia. So I did not particularly find that as far as cardiovascular mortality and benefit is concerned, any data supporting one to be better than other. Although there is enough data to support that probably fermented products are better. So can't say whether cow or camel milk or goat milk, one is more superior as compared to other.
Just a comment, the amount of saturated fat is more in cow's milk, but the total fat content is more in buffalo milk.
Yeah. Okay. So just a point which was a fleeting point in one of the slides here. Total fat content in cow milk is less as compared to buffalo milk. Total saturated content is also higher in buffalo milk. Now, as far as fat content and quality of fat is concerned, it depends from season to season and also depends a lot on what cattle are fed on. So there are a number of studies which I came across from Europe where they had number of studies where when cattle were fed grass, their saturated fat content was slightly less as compared to when cattle were fed more processed food. Also, it also depends on water intake in the cattle. So I didn't deliberately go into that literature, but it is possible that milk quality in grazing cattle who graze on grass and who are given enough water is slightly different from cattle who are reared with high protein and high fat content diets themselves. But so PUFA content is variable, saturated fat content obviously is higher in buffalo milk.
There is enough data to substantiate whatever you have said, that consuming dairy product is beneficial for the heart. But what about increased incidence of colorectal cancer, prostate cancer with milk consumption?
Yeah. So there is one study which said that increasing milk consumption increases risk of prostatic cancer. I did not come across a study which says that it increased risk of colorectal cancers. This one study again comes from, I think, Scandinavian countries. I'm not aware of milk consumption being proven to be related to colorectal cancers per se. But in general, milk consumption in European countries, especially milk product consumption in European countries is much higher. So there's no negative guidance to them anywhere, which I came across.
Just to tell you, there is enough data to substantiate that milk consumption increases IGF-1 activity, and as such milk contains a lot of IGF-1, and particularly in those cattle which are given recombinant factors for increasing the yield in milk. So all these factors, they add to the carcinogenicity of milk.
Yeah. Thank you.
Thank you very much, Dr. Joshi. And to the last lecture in this session, so I would like to invite Dr. Ritu Agrawal. Ritu Agrawal will speak on the topic of imaging for CAD prevention. So over to Dr. Ritu.
A very good afternoon to all of you. First, I would like to thank Team CSI for having me here. So this is a slightly different topic from what has been going so far. And basically, I'm a radiologist with a special interest in cardiovascular imaging, and that would be my topic of the topic of today's talk. So cardiovascular disease, as we all know, is the leading cause of death, and the coronary artery disease accounting for half of such death. And at least 25% of the patients who have acute non-fatal MI or sudden death had no previous symptoms. And therefore, atherosclerosis is a long, progressive, and a silent process. And we need to screen the patient because the process of atherosclerosis occurs actually much prior to the acute events. And for screening, when we have these list of non-invasive imaging tests, we have ultrasound for the carotid, abdominal, and peripheral arteries. We have echocardiography. We have a calcium score, a CT coronary angiogram, and the last of all, the newest one, the cardiac magnetic resonance imaging. And I'll be talking on the last three because that is what I do in my clinical practice. So, Framingham risk score is a simple low-cost test for cardiovascular risk stratification, which is used in a doctor's office. And it's based on the age, gender, blood pressure, cholesterol, smoking status, and the presence or absence of diabetes. Now, when we add a calcium score to this, it increases, it has an added value to predict the all-cause mortality and morbidity due to cardiovascular, due to coronary events in asymptomatic individuals. The calcium score is a simple test. It's highly reproducible. It is a low radiation test, and this is one point I would like to emphasize because the cardiologists are often worried about the amount of radiation, and it is less than 1 millisievert, whereas the background scatter radiation in a normal person not exposed to any study is 3 millisievert. So it is less than that. The coronary CT coronary angiogram has a radiation dose for about 1 to 5 millisievert. So it doesn't use contrast, so it can be used even in renal failure patient. It offers a direct assessment of the total burden of the calcified coronary artery disease. And it allows reclassification of the coronary artery risk disease in about 60% of the patients. Reclassification of DICS, I'm sorry, because at least 60% of the events occurs in patients who were initially classified into low or intermediate risks based on the Framingham score. And however, when we added CAC to it, it classified into a higher risk score. Now, both ESC, ACC, and AHA supports the use of CAC in as a primary prevention tool. To further exemplify what I'm trying to say is a short snippet. It's a 55-year-old male who presented to the doctor's office after his very close friend had a MI. This patient who came doesn't smoke, eats healthy, has no significant family history. The cholesterol are on the lower side, but not exactly controlled. He has mild hypertension, for which he's using an antihypertensive. He's asymptomatic, he doesn't have angina. But he insists that his friend had the same profile and still had a MI. So then a CAC score was done, which came back to 300. So the high score immediately moves him from a low risk category to a moderately high risk category. And this patient will benefit from adding lipid lowering agents and aspirin to improve his cardiovascular risk status. So this shows that the coronary calcium should be used in patients who are at a low to intermediate risk category and has no value in patient who is already on a high risk, because the patient on a high risk will remain high risk irrespective of the coronary calcium score. And they should be actually treated with medication, statin, aspirin, rather than checking on the calcium score. These are the numbers how we usually use the calcium scores. So when we have a patient who is coming to the office and we are doing a cardiovascular risk testing, if the patient has a low risk, then we continue the healthy lifestyle measuring, which includes sensible eating, physical activity, not smoking, moderation in alcohol, and all that stuff. And when the patient has a high risk category, then we go to the lifestyle modification, but we also need to add the lipid-lowering agents, control his blood pressure and diabetes. However, when the patient has an intermediate risk and we are not sure whether we want to add the lipid-lowering agent right now or wait for a certain time, then we do a calcium score. If the calcium score comes back to be low, that is between 1 and 10, we continue the healthy lifestyle measurements. If the calcium score is more than 300, then we know we have to add the LLA and for a better control of diabetes and hypertension. However, if the calcium score is intermediate, that is between 100 and 300, then it again becomes a shared decision making between the patient and the doctor, whether they want to start the lipid lowering agent as of now or they want to defer it for some more time. Now, an important point to note here that a high calcium score in an asymptomatic person doesn't mean block. It doesn't mean severe calcific coronary artery disease. It doesn't mean that the patient should go get a stress echo or a coronary angio or a stent or a bypass. This is very important because a patient who has a asymptomatic person and not a patient who has a high calcium score do not need further testing. Now, what a calcium score does is it adds value whether we want to start lipid lowering agent as of now or want to defer it. So, however, if the patient, if we are looking for secondary prevention, then definitely we need to add the lipid-lowering agent and the aspirin along with the lifestyle measures. So the limitations of calcium score are, the calcium score has a limited detection of plaque. It will not provide any information on the non-calcified plaques or the soft plaques because we do not use contrast. It has no functional assessment. It will not assess the non-coronary causes of cardiac symptoms such as the valve disorders or cardiomyopathy, which can't be done with a coronary angiogram. Then the calcium score is not suitable for all populations. For example, if we have a calcium score 0 in a person who is at a low risk, then it is highly reassuring. However, if the same score is in a person who has diabetes, who has high cholesterol, who smokes, then the value of this test becomes uncertain, and there is a lack of randomized controlled trial to show that if we have a strategy which incorporates the use of calcium score compared to a non-calcium score based strategy, improves overall survival. So a calcium score should not be used randomly. It is best done after discussing with the doctor and having a plan in mind. Now, should we repeat calcium score in future? Now, if the calcium score is high, then there is no point repeating it in future because the person is high risk will remain high irrespective of the number. If the calcium score is 0 and the patient is young, then we might consider repeating it in the next 5 years or so. So, especially if the patient has very low, fewer risk factors of cholesterol and blood pressure and are not on medical therapy. If the patient is already on statin, then again there is no point repeating a calcium score. However, if the patient is taking the medication regularly, however, if they are taking the statin sparingly, then and the LDL is high, then we can add a calcium score because those numbers sometimes have a positive impact on the patient following the medical therapy more closely. Now we talk about the role of CT in CAD prevention, both primary and secondary. So the CT, coronary CT is a first line, has a first line indication for evaluation of the symptomatic patient who comes to ED, has negative troponin values and are at low risk of ACS. A CT in these cases reduces the time to diagnosis and fosters early discharge, and it is more accurate for detection of patients who have obstructive CAD and would benefit from further invasive coronary angiogram. And the more recently updated guidelines 2021 by almost all societies gives coronary CT highest class 1 level A recommendation for evaluation of acute chest pain in a patient who is low to intermediate risk and has no history of known CAD. Now, if the patient has symptomatic with CAD, then the benefits of CT versus functional testing. So a CT can effectively rule out obstructive CAD and thereby act as a gatekeeper for invasive coronary angiography. And a CT is again superior to functional testing if we have a non-obstructive CAD, because when the coronary artery disease is not severe, the stress testing will be negative. And in those cases, a CT will pick up the disease early, and therefore early institution of lipid-lowering agent, antihypertensive, antiplatelet, and anti-anginal medications. And therefore CT will help in optimizing therapy in those non-culprit and optimizing therapy in these patients and detection of the non-culprit plaques. And it also rules out left main stenosis, which cannot be seen with the functional testing. Now, this is a very important slide because this shows the role of CT for plaque morphology. This can only be done with CT and not be done with a traditional catheter angiogram. We have 4 high-risk plaque features going from the left to the right. The first is the low attenuation plaque, where we have the low signal areas, low density area, which has a HU value of less than 30. So that is a low attenuation plaque. When we have a tiny speck of calcification on this low attenuation plaque with the size is less than 3 mm, it is called a spotty calcification. Now, when we have the transverse diameter of the artery at the site of the plaque, and we measure it, calculate the ratio at this site with a normal segment proximal or distal, and this ratio is more than 1.1, then it is called a positive remodeling. And this is a very important sign. This is a napkin ring sign where we have a normal enhancing lumen. Then you have a non-enhancing cap, non-enhancing plaque, and then you have a dense fibrous cap, which is called a napkin ring sign. So when we have any of these high-risk plaque features, we know that we are dealing with unstable plaques, which are more prone to rupture and increased risks of adverse cardiac events independent of significant CAD. So I repeat, it's independent of significant CAD. So even if the patient doesn't have obstructive coronary artery disease, these patients needs a much more closer follow-up and strengthening of the therapeutic management because they are more likely to develop significant events. Now, in women, there's a lower prevalence of CAD than men. However, the things are changing now. Women have usually smaller coronary arteries, so therefore they get more symptomatic even with a lower plaque burden. So these women have a lower plaque volume, smaller necrotic core, lower calcification, and therefore the calcium scores are usually lower than the corresponding male counterparts. But they can get more ischemia even with the non-obstructive CAD, which is very well detected with the CT angio. Okay, so for evaluation of the patency of the stent, which is a secondary prevention in CAD, as we can see in this image, there is non-enhancing areas within the stent showing the stent is blocked, and we can even see a thrombus at the LV apex. This is a bypass graft, a Lima 2 LED, which is very well seen with a CT. We can use a CT to evaluate the adjacent muscle, valves, and the lung parenchyma. So this is a patient who came with classic angina. She was a young lady of 37 years old. The coronaries were normal. But we can see there is significant mid-ventricular to LV apical hypertrophy. And this was a classic case of HCM, which was then followed up with echo and MR. And a primary ICD was placed because the scar was significantly higher. So comparing CT with CAG, CT actually selects patient better who might benefit from revascularization and therefore avoids the invasive procedures in a significant fraction of patient who might have a normal CAG. It's non-invasive and therefore the patient acceptance is higher. It can be combined with coronary calcium in the same setting. The congenital anomalies of the coronaries are much better seen on CT. It is a high negative predictive value on ruling out obstructive CAD. Coronary CT will evaluate the non-coronary causes of cardiac chest pain. And in specific situations such as coarctation where it's difficult to pass the catheter, a CT is better. Now we have these recent advances, FFR, use of AI, and pericoronary fat. These are all under evaluation and as of now are not available for routine use. Coming to the last part of my talk, the CMR and CAD prevention. So CMR is much less used, but it is actually the one-stop shop for everything. We have the cine sequences, which is essentially to echo much more clear and which can be used to evaluate the function and the mass. We have the edema sequences where edema is seen as high signal areas. We have the T1 and the T2 and the T2 star mapping, as in this case where there is a mid-myocardial scar, and if we do find a T1 value in this area, the T1 number is raised. We have the black blood the LG sequences where the normal myocardium is black, and whatever is white is a scar. Should I continue?
Madam, time is, we are actually already late.
Thank
you. No, you've just finished your, just.
So this is subendocardial scar where we have the white scar involving less than 25% of the myocardium and up to 50% of the myocardium in this case. Whereas this is a transmural scar where the entire myocardium is involved, which can be very well seen with MI and the, MR. And then we have the rest and the stress perfusion. So we see a perfusion defect which is seen as subendocardial hypodensity, but no scar on the corresponding late gadolinium enhancement image. Thus we know we are dealing with ischemia and not an infarct. So when we do a CMR in ischemic heart disease, what we all get? We get a scar, we get areas of microvascular obstruction, and we get LV apical thrombus. And in a patient with CAD, when we have late gadolinium enhancement, late MVO, and intramyocardial hemorrhage, which is seen as hypointense core on a T2 weighted images.
Dr. Ritu, we are running short, just wind up the things. Just wind up the things because we are very late in this session, no? So just wind up.
Okay, so this is the last slide. So what does CMR offers beyond? It can allow risk stratification, it allows in planning of treatment, it allows follow-up, it allows for screening of family members, and it reduces mortality and morbidity. To summarize, CT is a preferred non-invasive modality in low to medium risk patient. We can identify the high risk plaque features, which is a distinct advantage. It can be combined with CAC in the same setting. And CMR is accurate, reproducible, it has an unrestricted field of view, it has no ionizing radiation, and it allows characterization of myocardial tissue. Thank you so much for
Dr. Ritu for excellent presentation. Yeah. So with this we finish this session and hand over to the organizers. Yeah.
Thank you. Memento time. So may I call upon Dr. Ram Prasad from Bangalore. Dr. Sandeep Mathur, Dhananjay. Dr. Ruchi Gupta. Dr. Arvind Mathur. Professor Arvind Mathur. Ruchi Gupta is here. Professor Rajneesh Joshi. Dr. Rajneesh Joshi, has he stepped out? Dr. Ritu Agarwal. And the chairpersons, so Sandeep, you for Dhananjay Agarwal and Shailesh Doda. धनंजय का हो गया, तुम्हारा नहीं हुआ, संदीप का नहीं हुआ. Thank you. So we enter almost the last session of the Congress, and we are trying to mix up two sessions at the end. So may I request to chair Dr. Arvind Mathur, please. Dr. C.B. Meena. Dr. Chandraman. Dr. Sanjeev Gupta. Dr. Pradeep Meena. Dr. Rajiv Sharma. Sanjeev Gupta. So we have combining sessions on heart failure and guidelines. So first of all, we'll have heart failure session. Dr. Deependra Bhatnagar, sir. So we start with Dr. Nikhil Parchode on drugs and devices for heart failure.
Good afternoon. It's a vast topic about the drugs and non-drug treatment advances in heart failure. You all know about the two new developments in drugs as far as vericiguat and SGLT2 receptor antagonists are concerned. We know that vericiguat increases the intracellular cyclic GMP, thereby causing relaxation of the smooth muscles and acts as a vasodilator. Because the time is limited, I'm going to concentrate on non-drug device development in the treatment of heart failure, especially for real-world practice in India, as I have found it useful for the population. particularly about the left bundle branch block area pacing, which is more physiological and is an alternative to cardiac resonance CRT, or maybe an addition to CRT as well, in patients with heart failure and left bundle branch block. I'll start with one of my patients who is a 70-year-old gentleman who's a non-smoker, non-drinker, with a past history of hypertension and mild coronary artery disease. He's been short of breath over the last 2 years, which has been steadily increasing. He was admitted to the hospital with JVP elevation, systolic murmur at the apex, bilateral crepitation in the chest auscultation, and bilateral ankle edema. X-ray revealed cardiomegaly, pulmonary congestion, typical of heart failure. Blood tests revealed high anti-bro PNP, and other tests were unremarkable. ECG typically showed left bundle branch block pattern with a QRS duration of 150 milliseconds, first degree heart block, in normal sinus rhythm. A Holter monitoring showed sinus arrest and alternating right bundle branch block and left bundle branch block. A baseline echo showed that the dilated LA at 5.5 centimeters, left ventricular end diaphragmatic diameter of 63 millimeters, global hypokinesia with an estimated ejection fraction of 24%, with significant mitral regurgitation, moderate TR, and raised systolic pressure in the right ventricle. Angiography was not very exciting. Medical management was with ARNI, MRA like aldactone, dapagliflozin, and I could not give this patient a beta blocker because of what I showed of alternating RBBB and LBBB, first degree heart block, with an increased risk of going into complete heart block. So symptomatic sinus node disease with junctional bradycardia, alternating left bundle and right bundle branch block pattern on the ECG on the Holter. It's a pacing indication. Patient has non-ischemic cardiomyopathy with an LV ejection fraction of 24%, NYHA class 3, with left bundle branch block pattern on the ECG, QRS duration of 150 milliseconds, is a clear-cut CRT indication. The problem, a real-world problem here in India I found, is patient could not afford it. What would you do next? Well, you can add vericiguat to this patient. We can't add beta blocker to this patient. We have added dapagliflozin to this patient. So this is not uncommon that the patient is qualifying for CRT, but CRT is quite expensive when you look at the Indian population. And clearly this patient could not afford CRT. What would you do next? Well, we can now, during this last COVID pandemic, the latest development in device therapy has been the advent of left bundle branch block area pacing. And actually it's relatively easy to do. Medtronic, we must thank Medtronic for being the pioneer in developing a lead, particular lead called 3830 Select Secure Lead, and a C315 His bundle catheter, or C315 sheath for introducing the sheath for the lead. The lead does not have a hollow inside it so that we can put the stylet in it. So it requires the stability to be achieved with a sheath, as I'll show you in next few things. So Medtronic was the first to receive FDA approval for pacing the heart's natural conduction system with a Select Secure Model 3830 lead with proven safety and effectiveness. So we are now talking about the conduction system pacing, which I think is going to be adapted as more physiological pacing in normal pacemaker implantation as well. So step one is locating his bundle with fluoroscoping confirmation. When we go into RA, we advance the lead with clockwise rotation. We cross the tricuspid valve into RV. We start withdrawing the lead with counterclockwise rotation towards superior margin of the septal tricuspid annulus and look for his potential. I have now abandoned doing his bundle pacing because it's highly unpredictable. We cannot achieve all the time. And today's wisdom is to do left bundle branch block area pacing, which is quite easy to do. We can look at the his bundle, look at the conformation, and the beauty and easy thing is to look at left bundle branch block area, which is just 1 to 2 centimeters down and to the right of the his bundle in the RAO 30 projection, which is you are moving down the septum and above the apex. It's a large area which we can locate the left bundle branch area. Step 4, left bundle branch block pacing. The electrical conformation identify the W pattern before screwing in the lead in V1 and perform left bundle branch block pacing in unipolar mode. It's very simple. We start rotating the lead to put it inside the interventricular septum. And as we do that, we look for the appearance of an R in V1 as an RSR pattern. Number 2, we look for the ventricular activation time, which should be 90 milliseconds or less. We look at the lead 2 and 3, which should be effectively negative. And number 4, we look for the impedance, which should not come down below 500. These are the parameters, and we keep doing it. This is the W potential in V1 before we screw in the lead. And that's very important to identify on the septum so that we know that's where we're going to screw the lead in. Next, the select secure 3830 lead, we screw in 3 to 5 clockwise rotations for the screw to go inside the septum like this. We determine the depth of the lead implant, which should not be more than 8 millimeter. Why? Because of this. We know the lead tip is 1.8 millimeters, ring is 3.8 millimeters, the tip to ring is 9 millimeter, which is easily visible on fluoroscopy when we are doing the procedure. So what happens? In step 5, we determine the depth of the lead implant with electrical confirmation and transition of the left bundle branch block morphology, which is a W pattern, to right bundle branch block morphology. As the V in lead V1, R starts appearing as we are going inside the septum. It's very easy to see that. And the pacing in unipolar lead at high and low outputs, you can see that there's an RSR pattern which has happened in V1 as we have gone inside the septum. Evolution of V1 notching, morphology, QRS width and left ventricular activation time during LBBP lead advancement, we can see that. Generally speaking, the LV activation time should be 90 milliseconds or less. Number 1, there should be a R in V1, and we can see this transitioning happens as we start going inside the septum with screwing in the lead, as I've shown you the diagram. Step 5, we determine the depth of lead implant with serial impedance monitoring, which should not come down below 500 ohms. As we take the sheath out, you can see the fulcrum appearing because there is no stability of the lead without the sheath. This fulcrum sign is very important for us to understand the lead is now stable at the tip. And threshold testing then is confirmed with what your parameters you have got, and you're happy with that. Then we slit the lead with a adjustable slitter or with universal tool slitter, which is very easy to do. Slitting the C15 sheath is very easy, and take the sheath out, leaving the lead inside. This is how the lead should look, posteriorly directed in left bundle branch block pacing area, and the RA lead in anteriorly directed. And we achieve a very narrow QRS complex with this. And we did achieve that in this patient. You can see in echocardiogram the tip of the lead inside the septum, both in the transverse and the four-chamber view. And the post-left bundle branch block pacing echo, the left ventricular ejection fraction improved. The LV diameter became smaller. The MR almost disappeared. So we have, I don't have time, but there are now very well established, published studies showing that LBB area pacing is feasible, safe, and can extensively achieved in all our patients. We also have the data against the CRT, which is actually much better. But now what we are developing is LOT CRT. In addition to an LV lead through the coronary sinus, we put another lead into the septum. And that actually improves the QRS duration further and improves the ejection fraction, with every parameter improved as is shown here. In conclusion, left bundle branch pacing is a viable physiological pacing alternative to CRT and his bundle pacing. In patients with CHF, LV dysfunction, left bundle branch block, and high pacing dependence, in improving LV function, electrical and mechanical synchrony, and minimizing pacing-induced cardiomyopathy. Thank you.
Thank you, Dr. Nikhil, for the excellent overview and covering a very important area in patients who are not affording CRTD. Because of lack of time, we'll move to next topic, that is ARNI in heart failure, from heart failure reduced ejection fraction to preserved ejection fraction, by Dr. Satish Kaushik. Kaushik, sir. And Dr. S.K. Kaushik, sir. He doesn't need any introduction. So over to you, sir.
Good afternoon, everybody. First of all, I would like to thank my friend Dr. Rajiv and Dr. Deepak for inviting me for this very important conference. After listening to a wonderful, highly technical lecture by Dr. Pachre, which was and an excellent orator, I'm going to tell you only very simple thing. And it's a request from the industry also, so slides are from Novartis. See, ARNI was established as a class 1 indication for treatment of heart failure with reduced ejection fraction from class 2 and 3, 4. And this we have heard time and again. So I'm not going to cover that. The other area was now the heart failure is divided into 3. Heart failure with reduced ejection fraction, where echocardiographically derived ejection fraction is below 40%. Then from 41 to 49% is heart failure with mildly reduced ejection fraction. Previously it was called as a mid-range ejection fraction. And then heart failure with preserved ejection fraction, that is heart failure with more than 50% ejection fraction. Today I am going to tell certain characteristics of mid-range ejection fraction and some data from meta-analysis, because there are no large randomized control trial for this particular subgroup, and how it mimics more heart failure with reduced ejection fraction rather than preserved ejection fraction, and use of ARNI in this. So heart failure with mildly reduced ejection fraction, here most of these patients, more than 50%, will have coronary artery disease as the cause, and almost 26% patients will have renal dysfunction. This slide shows the differences between 3 categories of heart failure, where we see heart failure with reduced ejection fraction is more often seen in younger age group, while preserved ejection fraction usually is a disease of elderly. Ischemic heart disease is a common cause in patients with heart failure with mildly reduced ejection fraction, as well as patient with reduced ejection fraction. While atrial fibrillation, hypertension, they are more common in heart failure with preserved ejection fraction. So, a classification, heart failure with mildly reduced ejection fraction is useful categorization of patient with heart failure, and it shares the most important clinical features with heart failure with reduced ejection fraction. And that is possibly the cause that it was suggested that drugs
that are effective in patients with heart failure with reduced ejection fraction might also be effective in patients with heart failure with mildly reduced ejection fraction. And substantial proportion of patients with mildly reduced ejection fraction, they resemble with heart failure with reduced ejection fraction in having new ischemic events. Now, this diagram shows that heart failure with reduced ejection fraction has 58% cases because of ischemia, and 56% patients in this group of mildly reduced ejection fraction have ischemic etiology, so they are similar. While patients with heart failure with preserved ejection fraction have only 30% patients who have pure ischemic etiology. So what is the data backing the sacubitril valsartan in this subgroup of patients? In this subgroup of patients also, sacubitril valsartan improves the ejection fraction by almost 5.4% after its use for a year or so. Echocardiographically also, sacubitril valsartan will reduce the left ventricular and diastolic dimension as compared to valsartan. These are various meta-analyses, small studies which are there. So I'm just telling you that. Very importantly, sacubitril valsartan lowers the readmission rate by almost 7% as compared to valsartan group. So it is not only superior to enalapril, but also it is superior to valsartan, though valsartan is one of the component of RD. And what is the impact on clinical outcome associated with renal dysfunction, which is seen in almost 26% patients in this subgroup? You will see the patients who have CKD and heart failure with reduced as well as mildly reduced ejection fraction, they have a higher mortality as compared to the patient with heart failure with preserved ejection fraction. So it is more ominous to have a renal dysfunction in patient with mildly reduced ejection fraction and reduced ejection fraction. And what is its effect on renal dysfunction? What does this drug does? RNA improves the eGFR in patient with heart failure with mildly reduced ejection fraction in patient with CKD. Pre-treatment and post-treatment we have just seen almost 13% improvement in eGFR is seen. And I just discussed that in patient with CKD, this also improves the ejection fraction as the eGFR is also simultaneously improved, and 11% improvement in ejection fraction is seen in patients who have associated kidney disease. Guideline recommendations are also there, the ACC/AHA guidelines. Because of these reasons, apart from other 4 pillars and diuretics, ACE inhibitor, ARB and ARNI has been given 2B indications. And among patients with current or previous symptomatic heart failure with mildly reduced ejection fraction, use of evidence-based beta blockers for heart failure with reduced ejection fraction, ARNI, ACE inhibition, MRAs may be considered to reduce the risk of hospitalization and cardiovascular mortality, particularly among patients with ejection fraction on the lower end of this spectrum, that is below 50%. So this drug covers patients with ejection fraction below 50%, and the guidelines remain same as heart failure with reduced ejection fraction. Of course, the class is class 2B, not 2A or class 1. ESC guidelines also endorse the same, that sacubitril valsartan may be considered for patient with heart failure with mildly reduced ejection fraction to reduce the risk of heart failure, hospitalization and death. Of course, they are always prescribed with guideline directed beta blockers, MRA and other drugs. And what is the clinical evidence? This also comes from some of the meta-analysis, that this drug significantly improves anti-proBNP when it was prescribed to this group of patients. And sacubitril valsartan, in addition, improves quality of life. It significantly improves 6 minutes walk test and the quality of life score. Looking to all these things, in this subgroup, sacubitril valsartan reduces the risk of readmission and mortality rate. And according to this meta-analysis, there is 46% reduction in risk of readmission rate, 31% reduction in risk of 1-year mortality rate, and 38% reduction in risk of cardiac death. In addition, 17% reduction in risk of all-cause mortality is seen when patients are prescribed sacubitril valsartan. And one of the article in circulation wrote that it is time to adapt GDMT regardless of ejection fraction, and especially they meant this subgroup of patients. We have already read and discussed